I have done the share screen.
It's not yet showing. Let me just see if I can help you.
I seem to be having some issue with the screen share. Can you just give me a couple of minutes?
Okay, okay.
Can you see it now?
Yes.
All right.
Yes, we can see it.
Sorry, I apologize. I apologize for that. So it's visible and I'm as well.
Yes, it is visible.
All right. So I'll just start off. So I'll be talking today about pediatric optic neuritis in the setting of NMO, just like this previous case that we saw. So at the outset, I have no financial disclosures. Let me just talk a little bit quickly about optic neuritis itself. So optic neuritis, as we all know, is inflammation of the optic nerve. Now, it may be isolated or it may be associated with other systemic diseases. It's largely a clinical diagnosis when a patient presents to you with either loss of pain, often associated with eye pain, specifically pain on eye movements. The optic nerve may be normal or swollen, and the MRI, like you see here in this picture, shows us some contrast enhancement of the optic nerves, plus some other lesions. Now, coming to optic neuritis specifically in children, it's pretty rare, and there's very scattered literature out there. But one study from Canada, which looked at the incidence, showed that the incidence was about 0.2 per 100,000. But it's important to remember that when we look at all demyelinating diseases in children, optic neuritis accounts for about 1/4 or 25% of these. Like I said, it may be isolated, it may be associated with other demyelinating diseases such as M, which is acute demyelinating encephalitis, multiple sclerosis, or NMO. Mean age is 9 to 11 years, and the depends on the age. In prepubertal, it's the same in male and females, and post-pubertal age, there's a slight female preponderance. Now, how do we differ from the neuritis in adults? Most of these kids, 70 to 85%, will present with visual acuity of 20/200 or worse. So there's a higher chance of or more significant loss. They're more likely to present with bilateral vision loss. So this is in about 70%, which is much lesser in adults. Optic nerve swelling or papillitis may be seen in 73% of children, which is again uncommon because in adults, unusual compared to adults, because in adults the retrobulbar variety is more common. Pain in eye movements is seen in only about 50% of children, as versus more than 90% in adults. And of course, the other characteristics like field defects, color vision, and abnormal VEP. A typical workup for a case of optic neuritis, which would include, of course, a complete ophthalmic assessment, fundus pictures, the OCT, visual fields, or VEP where the diagnosis is not clear. An MRI of the brain and orbits with contrast is extremely important. A CSF analysis would be preferred, especially in those with bilateral optic neuritis. An NMO workup looking for NMO antibodies, the MOG antibodies, infectious workup to rule out TB, syphilis, Lyme disease, where it's endemic, and an inflammatory workup as well. I'm just quickly running through this case just to put things in perspective. This is a 13-year-old who came to us with loss of vision in the left eye for 5 days. His vision in that eye was counting fingers at 1 meter, and he had an afferent pupillary defect. He had no other neurological signs. This is his MRI, and you can see here the hyperintensity in the optic nerve on this coronal image. This is the post-contrast images where you can see the enhancement. And you can see how the enhancement continues all the way back, reaching the chiasm almost. He was treated with IVMP with partial recovery to 2200. The CSF was normal, the NMO antibody was negative. He was started on oral steroids, but he presented 3 weeks later, now with loss of vision in his right eye. Vision was 2200 both eyes. This is his fundus. You see here it's almost normal in the right eye, mild pallor on the left. So this is now second eye involvement. We consulted our neurology colleagues and thought, given the large segment involvement of the optic nerve, this could possibly be NMO spectrum. An MRI spine was done at this point, which was normal. We reinitiated IVMP and gave a longer oral steroid taper. After about 5 days, the vision had recovered to 20/80, 21/25. And in consultation with the pediatric neurologist, he was also started on rituximab. After 6 months, the child has been stable with good recovery up to 20/20 in the right, 20/30 on the left, some color vision loss on the left, as you can see. We did repeat the NMO testing, and this time it was positive. This is his visual field, and you can see some residual centrocecal or central scotomas in both eyes, slightly worse on the left. It's not a very reliable field, but the central loss is there. So NMO, coming to the specific topic, is a severe autoimmune disease of the CNS. It's characterized by recurrent inflammatory events, usually involving the optic nerve and the spinal cord. Now, traditionally, when it was first described, it was considered to be a monophasic disorder with simultaneous bilateral neuritis and transverse myelitis, and was referred to as Divick's disease. But our understanding of NMO has changed quite a bit since then, and especially the identification of the specific autoimmune antibody targeted against the aquaporin 4 water channel has changed our understanding of this disease, and we now know it's highly specific for NMO. Now, the term NMO spectrum disease was introduced in 2007. Once we realized that this is a large and varied spectrum, and it includes some of the seropositive patients where they don't present with the typical NMO lesions, or a minority which have other cerebral or diencephalic lesions. It also includes those who are seropositive but have coexisting other autoimmune diseases, and opticospinal MS, which was considered to be a particular phenotype of MS in Asia. In 2015, the terms NMO and NMOSD were unified. So now we have what is called NMO spectrum disorder. And this can be either with or without antibody positivity. So you can be seropositive or seronegative. These are the diagnostic criteria. I know this is a slightly crowded slide, but just bear with me. So basically the criteria are divided into whether you have NMO spectrum with aquaporin positivity, that's the first bit here at the top, or without positivity, or where your status is unknown. And then you have core clinical characteristics. Now let's look at these core clinical characteristics. These include optic neuritis, acute myelitis, area postrema syndrome, which is an episode of otherwise unexplained hiccups, nausea, or vomiting. This is because of the involvement of the dorsal pons, which is very particular to this disease. Acute brainstem syndrome, symptomatic narcolepsy, or symptomatic cerebral syndrome with NMOSD. Now that we know these core characteristics, you can diagnose someone with NMOSD when they have at least one core characteristic and a positive test, and you've excluded all other diagnoses. So this would be NMOSD with aquaporin positivity. In those with negative activity, you need at least two of those core clinical characteristics. You need, in addition, dissemination in space. That's, again, two or more different core clinical characteristics, and fulfillment of other MRI requirements is applicable. And of course, you have to have excluded all other alternative diagnoses. This is just a slide showing the pathogenesis of the disease, where you see that both T cells and B cells are involved. And it basically sets a complete inflammatory cascade into play, where the end damage is astrocyte damage, leading to demyelination, neuronal loss, and to the classic NMO lesion that we see. Now, specifically pediatric NMO, it's again not as common, but it accounts for about 5% of all NMO cases. What's important for us as ophthalmologists is that the first clinical event, that is optic neuritis, is seen in about half to 3/4 of these patients with pediatric NMO. Transverse myelitis is slightly lesser, that's 30 to 50% as the first presenting symptom. They have an ADEM phenotype. It has also been described following viral infections or in association with other autoimmune diseases such as SLE or Sjogren syndrome. The brain lesions in pediatric NMO, as compared to that in adults, are seen more often in those who are seropositive. They're usually large, about greater than 2 centimeters, and they tend to localize to the areas where there is high expression of aquaporin 4, such as periventricular regions of the third and fourth ventricles, the white matter, supra and infratentorial white matter, midbrain, and cerebellum. The involvement of the optic nerves, again, is very typical, where you get large segment involvement. That's about more than half the length of the optic nerve is involved, and frequently it extends posteriorly into the optic chiasm. In the acute stage, you can get enhancement with contrast. In the chronic stage, you will get more of an optic atrophy. The acute transferred myelitis is not, like we said, is not as frequent as neuritis, but it can occur frequently during relapses. You see large spinal cord lesions, just like we saw in the case that was presented prior to my talk, which usually span at least more than 3 contiguous segments of the spinal cord. The spinal cord can appear swollen and may show some patchy enhancement. The diagnosis would be, of course, based on the clinical features and the imaging features. This is again where an MRI with contrast is very helpful. The CSF analysis would typically show leukocytosis. You would look for oligoclonal bands, although they are present in less than 20%. Only one study has said about 30% of cases with NMO. They're more common in MS. Aquaporin 4 is very, very important. It can be tested in serum or CSF. The more commonly done ELISA tests are not as sensitive or specific. They can also give few false positives. The most sensitive and specific would be a cell-based assay, but it's not always available. It's also very important to remember that it can be negative initially, but can develop positivity over time. So even after 36 months of onset, 10 to 15% may test positive. It's also important to remember that about 40%, up to 40% of patients remain seronegative. So that does not exclude NMO. Other investigations which would be helpful would be a fundus photo for documentation, visual fields where the child is old enough or the vision is good enough, an OCT to look at the retinal nerve fiber layer thickness, and the ganglion cell inner plexiform layer complex thickness. You might see thinning, which is greater in NMO as compared to MS, and a VEP where the diagnosis is doubtful. Coming to the treatment would largely be divided into the treatment of an acute attack and then a more chronic preventative treatment to prevent relapses. In the acute attack, the most common, and as was done in the case previously presented as well, would be to give IV steroid. Now this is high dose, usually 30 milligrams per kg per day, up to a maximum of about 1 gram a day. Plasma exchange can be done in cases where there is continued deterioration, even with steroids. And IVIG therapy has also been used in these patients where there's a lack of response to steroids. The preventive therapy would largely be with immunosuppressive drugs. Some of the commonest ones tried are azathioprine. Rituximab is again a very good drug in these cases, and you can use serial CD counts and the B cell count to make sure that the immunosuppression is adequate. Mycophenolate mofetil, methotrexate, is used. More often, a combination of some of these therapies with steroid would be useful. There are newer therapies such as immunologic agents like eculizumab or tocilizumab, which can be used, and now aquaporimab, which is a specific anti-aquaporin 4 antibody. This is important. These are the drugs you would want to avoid. Now, these are the drugs that have been described in the treatment of MS, which is why it's important to make the diagnosis and differentiate between MS and NMO, because interferon beta, natalizumab, and fingolimod, which can be used in MS, can actually cause a flare-up or worsening of NMO. This would just be a general sort of treatment regimen. So you initiate your initial therapy with immunosuppressants like azathioprine or rituximab. You monitor the patient with blood and liver function tests. In case of a poor response or adverse events, you might switch from one drug to the other. If there's a continuing poor response, you might want to add plasma exchange and IVIG. So just to wind up the take-home points, NMO is not as uncommon in children as we thought it used to be. You would suspect NMO when there's bilateral neuritis, segment involvement of the nerves, and extending into the chiasm, the typical MRI lesion, especially area postrema syndrome. Serum aquaporin testing is not foolproof, and you might want to repeat if the initial test is negative. Immunosuppressives are warranted right from the get-go, and a team approach with neurology often helps in reducing the relapses, and a long-term follow-up is required. Thank you.
Thank you so much, Dr. Preeti. Dr. Mumbi.
Yes, thank you very much, Dr. Preeti, for the wonderful presentation. I'd like to invite any comments at this point. Any comments from the faculty and also from the people attending? Okay, as we are waiting for comments, I was just wondering, Dr. Preeti, normally according to the Optic Neuritis treatment trial, we are normally advised to give for 3 days the IV methylprednisolone. Any reason why you'd extend it to 5 days? So to just get clarification, because most of the drugs that we use here is methylprednisolone. Most of the drugs are not available with us.
That's a very good question, Dr. Mumbi. So firstly, it's important to remember that the ONTT was largely adults, and there has not been a trial like the ONTT in pediatrics. So in pediatrics, we are still sort of extrapolating information from adults and making our treatment paradigms. A lot of people believe, and we practice that here, we used to do that in LB Prasad as well, and here that in NMO spectrum disease, you need a longer steroid course. So that's the reason when you suspect NMO, especially in a recurrence, we would give 5 days and then follow on with a longer course with a more tapered, sort of a more gradual taper.
Dr. Christabel, do you have any questions from the chat box?
Yes, we do, Dr. Mumbi. There's a question from Taru. A question says, was plasmapheresis an option in this case? I assume this question is for Dr. Ilung, I think. Or maybe we go to the one for Dr. Preeti since we have to release her.
We did not think of plasmapheresis because the response to steroid and immunosuppression was good. Usually we resort to plasmapheresis or plasma exchange when the initial response isn't good or there's an acute transverse myelitis. But yeah, I'm sure the neurologists might differ. It can be considered, yeah.
Thank you so much, Dr. Preeti. There's yet another question. The question reads, do we have access to these tests?
I'm happy that this is Sailor. We have aquaporin for antibodies available in the private sector here. Both Lancet and Metropolis Labs in Lusaka offer the testing. The Lancet testing is actually quite inexpensive. It's actually much cheaper than MRI for our patients, whereas the Metropolis Labs tend to be more expensive. I don't actually know what type of assay either lab offers, though. I don't think either one is a cell-based assay, but they are available at least as an initial attempt.
Thank you so much, Dr. Preeti, for for answering those questions. No more questions, Dr. Mumbi? Oh yes, there's another one that has just come in. Would you use the same treatment if they came 2 weeks later after developing their OM?
Yes, I would. So even if it was 2 weeks later and has never been treated, you can still institute steroids. So there's no proof that it does not work after a certain period.
Okay.
Dr. Mumbi, can I make a small comment here?
Yes, Dr. VS.
Great talk, Dr. Preeti. You covered all the aspects. In fact, that makes my talk much easier. Just want to highlight the role of the 5 days of IVMP over here and the prolonged use of steroids. The reason is that over here, like Dr. Preeti showed in the pathophysiology, it is activating both the T cell and the B cell pathway, and the entire inflammatory cascade gets activated. The pathophysiology is different than a typical demyelinating disorder, and here the disease can lead to a cavitary necrosis of the affected cells. So this is going to cause a much more profound damage, which is not likely to respond to a shorter course of steroids. In fact, what we see is that majority of these patients will have a much slower course of recovery as compared to a idiopathic demyelinating optic neuritis or optic neuritis in MS. Therefore, it is now the standard of care that we give 5 days of IVMP for all patients where NMO is diagnosed. And if it was previously, then second episode, definitely. And I think in the West, especially, it is becoming very frequent that in a relapse, they will go for a plasmapheresis and even IVIG, especially if the patient is not responding. So it's related more to the pathophysiology. That's why we need to stress and give a longer course of steroids.
Okay, thank you very much. I think from now we are going to release Dr. Preeti. Thank you very much for finding time and giving us this presentation.
Thank you so much for having me. I'm sorry, I apologize, I can't stay longer, but thank you so much.
Thank you very much. We
Thanks,
appreciate
Dr.
it.
Preeti. It was great presentation.
Okay.
Thank you so much, Dr. Preeti.
So
Indeed,
at this time,
we're having a...
yes,
Dr.
Dr. Christabel, you can proceed, please.
Thank you so much. Indeed, it's a very interesting webinar that we're having right now and very insightful presentations so far. So we are taking it back to the registrars that are going to proceed with more presentations. Next, we have Dr. Tendai Mwale, who's going to give us her presentation in the next 5 minutes. Dr. Mwale, please pick it up. Dr. Tendai Mwale.
If Dr. Mwale is not ready, we can have Dr. Mashina maybe to come in.
Dr. Mashina, are you ready to present as we wait for Dr. Mwale?
Yes, I am. I don't
Yes,
mind.
please.
Thank you very much. If that's okay with everyone, I can proceed. Thank you very much for the opportunity to make this presentation, and greetings to everyone. I am Dr. Mashina Chomba with the Adult Neurology Unit at the University of Zambia Adult Hospital. I'll be making a brief presentation of a case that we have had managed within our services at the adult hospital here in Osaka at UTH. For this presentation, I have no financial disclosures to make. I'll be talking about a 40-year-old female who presented to us some years back with bilateral vision loss. Her history began 3 years prior to her presentation when she developed ascending numbness and weakness of both lower limbs within 5 days to a point of not being able to walk. She was treated with 2 months of oral prednisolone prior to her presentation at that time, and she made a near full recovery after the prednisolone treatment. 2 years ago, however, she had a similar episode recurring, and it was associated with urinary retention and constipation the second time. Her MRI at that second presentation revealed a mid-thoracic disc bulge, but there was an extensive intrinsic spinal cord signal abnormality that was also noted. She was taken to the theater by the surgeons for the bulge that they had noticed in the disc for discectomy, but she didn't respond very well and did not report any major response to the surgery. And she was restarted on her high-dose prednisolone for another 3 months with a slow taper 3 months following that. So she regained some strength in her legs, but she was still non-ambulatory after this steroid treatment. A month after completing the steroid therapy, she developed another episode of paraplegia with sensory loss in this time in her lower limbs. So the repeat MRI then showed another disc bulge, but there was worsening of the intrinsic spinal cord signal. She was taken to theater a second time for another discectomy for the disc bulge that was noted on the scan. There was little response after the operation, and a week after surgery, she experienced a worsening of her limb weakness with complete bilateral vision loss on this other presentation. So she reports that the vision loss occurred over 24 hours, which initially started with cloudiness of her vision, progressing to a point of not perceiving light on both sides the following morning when she woke up. But she didn't give any other neurological symptoms. So she was HIV negative on her presentation, and she had been, at the time presenting to the neurology side, she was on prednisone on 20 milligrams once a day orally. She had no other significant family history. She was married with 2 children and worked as an administrative assistant with no history of alcohol, tobacco use, or any other substance use history. So on our exam, when she finally presented to our service, she had a normal mental state exam. Her language was normal. On her cranial nerve exam, the pupils were dilated and unreactive to light, both sides, and there was no light perception in both eyes. The fundoscopic exam revealed a pale disc bilaterally. The extraocular movements were normal, facial sensation was normal, and the face was symmetric. Hearing was intact to figure rub, palate elevated symmetrically, and the shoulder shrug was 5 out of 5 bilaterally with a midline tongue. There was normal bulk, tone, and power in both upper limbs, but she had a spastic paraplegia with normal reflexes in the upper limbs, but she had exaggerated reflexes of 3+ at the knees, bilaterally with sustained clonus at the ankles and upgoing toes. Her sensation was absent to all modalities, and she had a T4 sensory level on her exam. There was normal coordination in both upper limbs, and we weren't able to assess her gait. So we initiated investigations, and amongst them, we decided to investigate for a neuroinflammatory process, and her serum aquaporin 4 tests were done at a private lab, and they were positive. So this established our diagnosis of neuromyelitis optica that had been going on for the time of her complaints. I'll just highlight a few points pertinent to the case. And the first, I think, has already been talked about briefly, that the first manifestations of NMO can include optic neuritis, transverse myelitis, and sometimes we can have both. And we can have transverse myelitis occurring up to 1/3 of patients with NMO. Initially present with optic neuritis at risk of subsequent attacks of myelitis as well. And the myelitis that's caused by is quite aggressive and tends to be quite disabling, presenting as this longitudinally extensive transverse myelitis, which was discussed earlier. I have a slide here that exemplifies this lesion on MRI. What we'll see is a large area, extensive area within the spinal cord, extending more than 3 spinal cord sections. And then we have other lesions in other areas of the central nervous system, within area postrema, as well as the brainstem. So to conclude, a few takeaway points. Most patients with NMO who initially present with optic neuritis need an early diagnosis that will be crucial to prevent subsequent attacks resulting from myelitis. And these can be quite disabling, including disability from the optic neuritis and the myelitis. Transverse myelitis can be a first presentation of NMO as well, and a longitudinal extensive lesion on MRI should support the diagnosis. And early recognition and treatment through multidisciplinary approach can help manage the progression of the disease. Thank you very much.
Thank you so much, Dr. Mashna, for that case presentation of the adult NMO. Right away, before we take any more questions, we'd like to have another case presentation, and that is from Dr. Serene Mulugwa, who's from ophthalmology, UTH. Dr. Mulugwa. Dr. Mulugwa, are you there?
Yes, I'm here. Just a minute.
You have our attention.
So I'll get right into the presentation. I'm presenting the history of a 41-year-old female banker who's a resident of Lusaka. She presented to UTH on the 29th.
We can't see your slides. Could you share your slides, please?
Okay, just a minute. Can you see now?
No, Doc, we still can't see.
Not yet.
Are you able to see now?
Yes, yes, we can see it. You can just start slide share.
Okay.
Thank you.
All right. Yes, so her chief complaint was diminution of vision in the right eye for 3 weeks. And this history was of sudden onset with no history of trauma. It was affected lower visual field, with down movement, no other symptoms of no headache, no nausea, vomiting, no neurological deficit. And prior to presentation, she had been told that she had a swollen retina. Her past ocular history, but had a similar incident happened in 2018, but it was after 2 days. The drug history prior to coming to our institution, she had received 3 doses of IV methylprednisolone for 3 days, followed by a low dose of oral prednisolone for 7 days. She had also been on topical drugs such as ifenatimol, moxifloxacin, and temozolomide. So she also had done some investigations there, including a CT scan with brain and orbit. This was reported as normal, but we didn't have any images available. She also done a visual field test, OCT of the retinal nerve fiber layer, and other photos. The last 2 were reported as normal. Then this was the visual field, which showed the scotoma on the right eye. The left eye was normal at that point. On examination, visual acuity was noted to be reduced on the right eye, which was noted to be counting fingers at parameter with no improvement on pinhole. The other positive finding was RAPD of grade 3 in the right eye, as well as fundus findings of disc elevation, blurry disc margins, tortuous vessels, and obliterated cap. The rest of the anterior segment was normal on the right. On the left eye, all the examination findings were normal. So a visual diagnosis of right eye papillitis was made, and the plan was to do a uveitic profile, full blood count, visual field, imaging. But before the patient could do this investigation, she was lost to follow. She went to the hospital that she came from before presenting to TH. So she returned 4 months later with a complaint of loss of vision in the left eye, which was the fellow eye. And this was associated with pain on movement of the eyeball, especially when looking upward. Her examination findings, the right eye had the same visual acuity, it didn't change, and the RAPD grade 1. And on fundoscopy, there was optic disc pallor. The other examination findings were normal. Color vision was deferred because of the visual acuity. Then on the left eye, the visual acuity had gone down to 60, no improvement on pinhole. Color vision was 118. The rest of the examination was within normal limits. So a diagnosis of left eye retrobulbar optic neuritis was made on the left eye. On the right eye, a diagnosis of optic disc atrophy, status post atypical optic neuritis was made. And this was attributed to a demyelinating disease, possibly optic neuromyelitis optica or multiple sclerosis. The patient was advised to do uveitis profile and NMO antibodies, fasting blood sugar, chest X-ray, OCT, ganglion cell layer, and was started on IV methylprednisolone followed by high-dose oral prednisolone, as well as supportive treatment. So the aquaporin 4 antibody was found to be positive. That's 1 in 320. The other investigation findings were essentially normal, except for a mildly raised ESR, and the MRI was reported to have SATO2 hypersensitivity at 6, but we were unable to obtain the images by ourselves. These were the investigations. To your left, there's a ganglion cell analysis, which essentially shows thinning of the ganglion cell layer on the right. Then to the right of the screen, you can see the retinal nerve fiber layer. And you can see on the right eye, there was retinal nerve fiber layer thinning, but the left eye was normal. So after we saw her, the neurologist also saw, and they noted improvement in vision, but the patient could just make out shapes and colors, but not the details of those shapes. So they advised that we increase the prednisone 100 milligrams, and they added azathioprine and septrin, and also counseled the patient on prognosis. Then she was reviewed some time after that, and rituximab 1,000 milligrams IV was added, and she received this infusion on day 1 and day 15, and she's supposed to repeat it every 6 months. So she's still waiting to do this second dose of rituximab. And this is the end of my presentation.
Thank you so much, Dr. Muluwaserenje. That's a case presentation. So indeed, we've had so far 3 adult NMO case presentations, and we're yet to have 1 more before we move to the faculty. Dr. Tendai Mwale, are you ready to present to us? Dr. Tendai Mwale, you're muted.
Can you see my screen?
We can see you, but you are not yet sharing.
All right. Okay. Can you see my screen now?
Yes, please. We can now see it.
All right. Okay. Thank you very much for this opportunity. My name is Tendai, a 3rd year ophthalmology registrar at Kitwe Eye Hospital. And I'm going to give you a case presentation of a patient we had who had a delayed diagnosis of neuromyelitis optica. Okay, this was a patient who was first seen by a 1st year registrar. And I have no financial disclosure to or interest with the presented material in this presentation. Okay, so the case is of a 36-year-old male, BC, a High Court clerk from the Copperbelt province of Zambia, who was first seen on the 4th of September last year at Kitwe Eye Hospital. He came in with a complaint of painful right eye for 2 weeks. The pain in the right eye was of spontaneous onset, and it was gradually increasing in intensity. It was worse with eye movement, and there was associated decrease of vision. He had no associated history of fever, nausea, vomiting, or neurological deficits, and he had no complaints in the other eye. On the examination, in the right eye, his visual acuity was 624, and after refraction, his best corrected visual acuity came to 6.6 with a sphere of 2.4 diopters. In the left eye, his vision was 6.9, and with a refraction of -1 diopter sphere and the cylinder of -1, his vision came to 6.6. Contrast sensitivity and color vision was not done, but the intraocular pressure in both eyes was 20. We did a slit lamp examination, and in the right eye, we had a normal anterior segment. However, on fundoscopy, we had disc edema in the right eye. In the left eye, both anterior and posterior segments were within normal limits. An impression of optic neuritis in the right eye with simple myopia was made, as well as myopic astigmatism in the left eye was made. Differentials for the cause of the optic neuritis were syphilis, sarcoidosis, and multiple sclerosis. Investigations were done, but when I was reviewing the file, I couldn't find the results. However, the HIV test was negative, and we had requested an MRI of the brain and the orbit. The patient only came back a month later with the MRI reports, which was within normal limits. However, it showed lesions in the ethmoid sinus, and so the report stated that they were suspecting ethmoidosinusitis. And so the patient was referred to the University Teaching Eye Hospital, which is in another province in Zambia. And it took him 2 weeks to get there. And so the ENT specialist reviewed the patient. This was 7 weeks later from presentation. And on examination and on reviewing the MRI, he said there were no abnormalities he could detect. However, he was very concerned about the sudden drop in vision, and so he referred the patient to UTH Eye Hospital. And at the UTH Eye Hospital, the patient presented with loss of vision in the right eye and reduced vision in the left eye for a month. He had associated weakness of limbs and he had history of phantom headaches. However, he had no fever. On examination, at this time, his visual acuity in the right eye was no light perception, meaning he had just lost vision in the right eye. And in the left eye, he was able to perceive light with inaccurate projection. On examination, on slit lamp examination, he had a relative apparent pupillary defect in the right eye with the pale disc. In the left eye, both the anterior and the posterior segments were within normal limits. So the ophthalmologist made an impression of optic disc atrophy in the right eye and retrobulbar optic neuritis in the left eye. And their plan was to start high-dose methylprednisolone, 500 milligrams twice daily for 3 days, as well as oral calcium, oral omeprazole, do baseline investigations and consult the neurology. The neurologist reviewed the patient, and after examination and history, they made a diagnosis of retrobulbar optic neuritis. The differentials was top on the list, Neuromyelitis Optica, given the severity of the disease and the bilateral involvement. The other differentials included ophthalmic syphilis, neurosarcoidosis, and vitamin B12 deficiency. They did quite a number of investigations, and their results were as follows. The full blood count, the rapid plasma reagent, the random blood sugar, and vitamin B12 were all within normal range. The angiotensin converting enzyme was slightly reduced at 15 international units, and most importantly, the aquaporin 4 antibody titer was positive. And so an impression of a diagnosis of neuromyelitis optica was made. This was almost 2 months from the test presentation. The plan for the neurologist was to continue the patient on methylprednisolone at 1,000 milligrams IV daily for 5 days, start oral prednisolone at 40 milligrams once daily for a month, and omeprazole as well. The patient was reviewed 2 weeks later, and his vision had improved from not perceiving any light to 636. The neurologist then added azathioprine 100 milligrams twice daily and asked to follow up the patient after 3 months. The subsequent neurology visit after 3 months, the vision continued to improve and it moved from 636 in the left eye to 690. However, he had still lost vision in the right eye. The patient complained of azathioprine being too expensive, and so the patient was transitioned to methotrexate, and folic acid was added. Prednisolone was continued, and it was tapered by 5 milligrams weekly, and the patient was to be followed up after 3 months. So the patient was due for his review a month ago. However, because of the COVID, he was not able to travel to Lusaka, and so he came to the Kito Eye Hospital. And his vision in the right eye is still lost. He's not perceiving any light in that eye. And in the left eye, his vision is 612. Best corrected visual field is 612. He still has a relative apparent pupillary defect in the right eye. And these are his fundus features. As you can see, he has obvious optic atrophy in the right eye. This is the end of my presentation. Thank you.
Thank you so much, Dr. Tendai Mwale. Indeed, thank you to all the registrars that have presented these cases. So far, we've had two pediatric cases and 3 adult cases, which are just showing us that NMO is not as uncommon as we might have earlier thought. So thank you so much for this wonderful case presentation. At this juncture, may I please call upon Dr. Mumbi to take it up?
Okay, so far so good. As Dr. Christabel has mentioned, we have had 3 adults actually, 3 adult NMO, and also 1 case presented from Dr. Chamba. So I'll quickly.
While we're getting Dr.
Are you able to hear me? Am I audible? Okay, yes. So I'll straight away go ahead and introduce.
Yes,
you are. Yes, you are.
Yes, I'll introduce Dr. Virender Sachdeva, and then I'll allow Dr. Kafula to introduce the other 2 speakers. Yes, once again, indeed, it's my pleasure again to have this privilege of introducing our second faculty, who is Dr. Virender Sachdeva. He's a consultant pediatric ophthalmologist, strabismus and neuro-ophthalmology at LV Prasad Eye Institute, GMRV campus in Vishakhapatnam in India. He did his pediatric ophthalmology fellowship at LV Prasad, Hyderabad in India, and also went ahead and did his clinical research fellowship in neuro-ophthalmology at Emory University. His areas of interest are complex strabismus, reoperations, imaging strabismus, amblyopia, and neuro-ophthalmology. So I understand these for some of our colleagues, these might be big terminologies, but I think it's important we start getting used to such terminologies like amblyopia because of its importance in our environment. So I'm also privileged that he was my mentor, and I was attached with him for 3 months when I just started doing my fellowship. So he has been, whatever foundation I've had, I can actually say this is attributable to him. Thank you, Dr. VS, and the floor is, oh, sorry. We are going to invite Dr. Kafula to do the introduction for the other 2 speakers. Dr. Kafula, are you there?
Yes, I am. Yes, I am.
Are you able to share the screen? Would you want me to share the screen on your behalf?
Yes, I'm just.
Great.
Can you see my screen? Can you see my screen?
Yes, Dr. Kafla, we can see it. You can click slide share. Please just click slide share. On your PowerPoint.
Just give me a minute.
Yes.
Okay, so it is my privilege to introduce Dr. Diana.
Excuse me, Dr. Kafula. Your screen is not yet shared. Could you please share your screen? Oh, sorry, the slides. Yeah, so just go to slide share for the PowerPoint.
Can you see it now?
Yes, we can see it, but it's not yet on slideshow.
On editing first, and then you go.
Is that better?
Okay. Okay, there's more. Would you allow me to share the screen? You can just stop sharing. I can share for you.
Yes, yes, yes. Go ahead.
Okay, thank you. Yes, Dr. Kafla, you can proceed. You are muted.
Okay, so it is my honor and privilege to introduce Dr. Diana Saylor, who is an assistant professor of neurology in the division of neuroimmunology and neuroinfectious diseases at the Johns Hopkins University School of Medicine. She is also our director of inpatient neurology service here at the University Teaching Hospital, and her research interests include neurological complications of HIV, demyelinating diseases, and developing systems for neurological care in resource-limited settings. And the next presenter will be Dr. Mumbi. Thank you. This will be Dr. Elika, who is an assistant professor of imaging sciences and a section head in the pediatric neuroradiology, associate fellowship director and neuroradiology at the University of Rochester in New York, USA. She's also the director of pediatric neuroradiology, currently holds positions in multiple hospitals in New York City. She did her postdoctoral training and multiple clinical and research fellowships in India and in the USA. And she has multiple publications, including journal articles in both peer-reviewed and non-peer-reviewed journals. Thank you so much for having taken some time to share this, your knowledge with us on neuromyelitis optica.
Okay, thank you for those wonderful introductions. Before we can go for Dr. VS's presentation, I'd like to invite the faculty to make some comments on the three cases that have been presented so far. And then from there, you can please proceed in typing in your questions. Dr. Christabel is going to read for us. And if you have any question that you'd want to ask verbally, you may come in, please. Shall we start with Dr. Virender? Do you have any questions or any comments that you would like to make on the cases presented so far?
Yeah, Dr. Mumbai, thank you very much for the kind introduction. You bring back the memories of your wonderful stay here in India in Visakhapatnam. I think all the cases are very interesting. The way the diagnosis is challenging in all of them is the main key over there, especially the case where it was diagnosed to have a compressive myelopathy and the patient presented with actually 2 years ago there was a history of a myelopathy. So it's possible we might think that the things are happening because of the compression, because of the disc prolapse. But at the same time, the degree of the disc prolapse is significant over there. And it took 2 years later when the visual acuity started showing a change, then we could find. Maybe we should revisit the MRI at the initial exam and see that whether those findings were more suggestive of a neuromyelitis optica kind of a problem. As Dr. Preeti pointed out, and I have briefly kept the revised diagnostic criteria as proposed in 2015, they suggest that we need not have the entire spectrum at the presentation, but even with one core symptom, we should be able to diagnose. I think that is the key we all need to keep in mind.
Dr. Sela and Dr. Erika, would you want to come in?
Do you want me to present now, Dr. Mumbi?
Not yet. I wanted to ask if you have any comments on the three cases that have been presented so far.
No, actually, when I do my presentation, actually, it'll become more evident. I think I'd probably leave it to there.
Okay. Okay. Dr. Sela, are you there?
Yeah, I think she needs to be added to the panel. She has by mistake exited the panel.
Okay, okay. I think at this point, I'll hand over to Dr. Christabel to see if there are any questions.
Yes, Dr. Mumbi, there's one question. I think this question was meant for Dr. Preeti. Immaculate asked, what has been the outcome of the cases that you've been having? I think this should have been answered before she left. So I don't know if it can be answered now, Dr. Mumbi. I'm not sure. That's Immaculate was asking whether the cases that Dr. Preeti had presented, what the outcomes have been.
Okay, I think she partly mentioned that. I'm not sure whether I'm mistaken. Unfortunately, she's not here with us. So it might not be easy for us to respond to that question unless there are any other questions.
Sorry, thank you.
At the moment, no other.
Thank you for re-adding me. I just wanted to comment about the case that Dr. Chamba presented as well with the recurrent myelitis that actually went to theater twice. We unfortunately don't still have her MRI, but once she finally presented to us on the neurology side, we re-reviewed all of her MRIs. I really think that the thoracic disc bulge that they found was incidental both times, and it just an inflammatory myelitis was not on people's differential. And so the reason we chose to present that case was actually because it had been sort of a misdiagnosis for several years, and as a result, she had accrued a lot of disability because of that. We never saw her for her myelitis on the neurology side. She was managed by neurosurgery. And so I think it's just an excellent teaching point that we need to have these in our differentials, early on, so that we can try to get patients on appropriate treatment and prevent this type of disability from accruing as well.
Okay, looks like we don't have any questions for now. Dr. Kafula, would you want to come in? Any comments? Okay, at this point, I'll call upon Dr. Virender Sachdeva to give us the next presentation. And then from Dr. Virender Sachdeva, we'll move on to Dr. Erika and then to Dr. Sela. And then afterwards, we are going to have a few questions, and then we'll have a pharmaceutical presentation.
Thank you very much, Dr. Mumbi. Am I audible and are the slides up there?
Yes, the slides are up and they're visible.
Okay, very good. Thank you so much once again for the kind invitation and to be able to participate in this interesting webinar. I think we have seen a spectrum of cases already presented, and each one of them pose different challenges in the management of neuromyelitis optica. And we learned in Dr. Preeti's talk that optic neuritis is most commonly the presenting symptom in NMO in about 2/3 to 3/4 of patients, and myelitis in about 1/4 of them. So given this current understanding of various demyelinating disorders in the current scenario in 2020, important thing is that I might like to stress again. So neuritis. classical manifestation everybody used to feel until these refinements in the diagnosis and imaging became available. Then it could be a hallmark of multiple sclerosis, which has been the mainstay over the last 20-30 years, ever since the ONTT showed us about the relation of optic neuritis and the multiple sclerosis. It could be this or MOG related optic neuritis. So how do we approach further? So I'll try to highlight with some case scenarios and try to put an algorithm and tell very briefly about what do we see as NMO in our setting in India. So let's begin with a case one. This is a 19-year-old woman who presented with sudden onset blurring of vision in her right eye. There was pain on eye movements, but no other neurological complaint. Visual acuity at presentation was only counting finger at 1 meter in right eye and was normal left eye. Anterior segment examination was within normal limits except for right eye grade 3 RAPD. As we can see in the attached fundus photographs, the media was quite clear. The fundus was actually looking quite normal and the optic disc did not show any significant pathology. So at this point of time, we made a provisional diagnosis of right eye optic neuritis and we obtained imaging. This is to the left side of your screen, you can see the coronal flare sequences showing the increase in the volume of the optic nerve on the right side, along with presence of hyperintensity. And the same section, when seen on the T1 post contrast, shows an increase in the size and the brightness of the lesion in the optic nerve, suggestive of post contrast enhancement. This is highly suggestive that the patient had optic neuritis, which was very much confirming with our clinical diagnosis. So in addition to this, the rest of the brain MRI was normal for the patient. So we treated the patient as idiopathic isolated demyelinating optic neuritis, and as per the ONTT protocol, patient was treated with IV steroids followed by oral steroids, and there was gradual improvement noted with treatment. 2 weeks later, the patient had remarkable improvement with visual acuity coming back to 20/20. Color vision was slightly subnormal and the grade 1 RAPD was still present in the right eye. This is the fundus picture showing almost normal appearance at this point of time. And this is a classical presentation of isolated demyelinating optic neuritis. The second case let's move to the second case. This is a little different case. I'll highlight the key pointers. This is a 25-year-old woman who presented to us with subacute decrease in vision in her left eye for 1 week duration. She denied any frank pain or pain on eye movements, but did report periocular discomfort. She denied any positive history of fever, vaccination, trauma, any body weakness, numbness, or any other neurological deficits. But the fundus examination showed few important findings. This is the fundus picture of the right and left eye. We can see that in the left eye, there is a minimal hyperemia of the nasal portion of the optic disc. In the right eye, we can see that the rim appears okay in the superior nasal and temporal areas, but there is mild temporal pallor. And it is seen even better on the red-free photographs. In this patient, the visual acuity at presentation was 20/20 and counting finger 1 meter in the left eye, but there was no RAPD. And the color vision was 10 out of 17 color plates were identifiable by the patient in the right eye. So given this, we were a little surprised that patient has a unilateral presentation, but there is no RAPD, as well as the patient does also have a significant pallor in the right eye. Given this, it was suggestive that the patient is possibly not having the first episode and possibly its second episode, as well as there is possible subclinical involvement in the right eye. So we did the visual fields in the right eye, which shows small reduction of the small peripheral constriction of the visual fields, and there is a small central depression as can be seen here. We can see that foveal sensitivity is reduced. We went ahead and did the visual evoked potential, which showed that the amplitudes were reduced in the right eye as well for the smaller stimuli and was reproducible only until the 60-minute stimulus of our stimulus. And then in the left eye, we could not even elicit even for the large size stimuli. So pattern VEP was extinguished while a reproducible flash VEP was possible. So this suggests that the patient possibly had bilateral involvement even at this stage. We obtained MRI orbits and brain with contrast, and as expected, we can see a bright hyperintense lesion in the left optic nerve. In addition to that, the brain parenchyma showed periventricle radially oriented lesions, which were highly suggestive of the pathognomic Dawson's fingers, which are seen classically in multiple sclerosis. So given this, we made our diagnosis of optic neuritis in multiple sclerosis. And as compared to the first case, what's different? So there was definite pallor in both eyes, although it was much more obvious in the right eye, but there was very minimal pallor in the left eye that could be made out. It was suggested it was not the first episode. There was lack of relative afferent pupillary defect and possible subclinical involvement in right eye. And MRI lesions were present not only in the optic nerve, but also in the brain parenchyma. Therefore, given this, we proceeded and made a diagnosis of multiple sclerosis. This is representative images from different patients which show that what are the likely lesions in multiple sclerosis. They are classically periventricular, round to oval lesions. They can also be seen in the subcortical white matter in the corpus striatum and in the subcortical white matter. And the chronic old lesions might also be seen, which do not show enhancement on the post-contrast images, but they would rather appear as dark areas. So we'll not go much more into the history in the diagnosis of multiple sclerosis here, but we'll move to the third case. This is a case of a 25-year-old woman who was initially thought and diagnosed to have multiple sclerosis. The patient had presented to us in 2011 with complaints of sudden onset decrease in vision in both eyes for last 2 days. And at the time of presentation, there was significant past history. So the patient had a history in 2003. There was a non-compressive myelopathy, and the patient was treated with methylprednisolone course for 3 days, and there was remarkable improvement. 1 year later, she had a history of left side third cranial nerve palsy. At that time, she was diagnosed to have multiple sclerosis, possibly based on her MRI findings, which showed demyelinating lesions in midbrain and thalamus. So this is in 2004, where we did not have an understanding of neuromyelitis optica, but currently we know that these lesions, demyelinating lesions in midbrain and thalamus, are not typical of multiple sclerosis, but might be seen in the neuromyelitis optica spectrum disorder. In 3 years later, in 2006, she had recurrent episodes of ataxia, vomiting, and then she was again treated with IVMP. Today, we know, as Dr. Preeti highlighted in her previous presentation, these are suggestive that they are involving the area postrema. Therefore, they are presenting with ataxia, vomiting. So therefore, possibly it suggests a brainstem involvement. Given these positive findings, we were little concerned at the time of presentation. On examination at the time of presentation, the patient had very poor vision in both eyes. Rest of the anterior segment examination was normal, and confrontation visual fields were remarkably constricted in both eyes. As the patient was a known case of multiple sclerosis, and old MRI had recordable demyelination with sudden onset decrease in vision, we thought that either it's a recurrent episode of optic neuritis, but given the key pointers, I was thinking also of possible neuromyelitis optica. This was possibly one of the first patients where I diagnosed as neuromyelitis optica. So we treated with IV methylprednisolone, calcium carbonate and ranitidine, and ordered MRI brain and cervicothoracic spine. This is the MRI pictures of the patient, which does show presence of hyperintensity, but also thinning in both optic nerves. The rest of the brain parenchyma, as you see here, is quite normal, but it is the MRI spine which shows the classical longitudinally extensive transverse myelitis involving the segments, lower cervical segments, as well as extending into the thoracic spine. The patient was also ordered to have serum aquaporin antibodies, which were positive, and a final diagnosis of optic neuritis in setting of neuromyelitis optica was made. Over a period of time, the patient slowly had improvement in her visual acuity, and the color vision was still subnormal, and low contrast visual acuity was slightly subnormal, but the visual fields also gave us some more pointers. We can see that there is still a marked depression in the visual fields 2 weeks post treatment, and then we can see that there is a bitemporal hemianopic kind of field effect along with central depression. So this suggests that the patient possibly had a chiasmal involvement, which we could not see on the optic nerve imaging or in the brain MRI, but possibly the visual fields do suggest that the lesion was possibly close to the optic chiasm. And today we know that optic chiasm involvement is more commonly seen in patients who have NMOSD. These are the various representative images of another patient, which shows that long segments of optic nerve involvement, presence of optic chiasm involvement, relatively normal brain parenchymal imaging, such as there is lack of white matter lesions, and longitudinally extensive transverse myelitis are pointers that the patient might actually have neuromyelitis optica. Therefore, we will remember that if we have a relatively normal MRI of the brain, but optic nerve involvement, it is something that we should keep in association with neuromyelitis optica spectrum disorder. And there could also be involvement of the medulla and the area postrema, which is located in the brainstem, which can have the presentation with hiccups and intractable vomitings. This slide, Dr. Preeti showed that there is cascade of activation of T cells, B cells, macrophages, and this leads to actually a cavitary necrosis, which can cause a permanent damage within a single episode of neuromyelitis optica. And therefore, there is possibly more severe visual loss, there is possibly much slower recovery, and patients might not have a good recovery even after the single episode of optic neuritis in NMO. These are the old diagnostic criteria which were first proposed, suggesting history of optic neuritis, history of acute myelitis, presence of either one of them, but along with that we should have presence of two of the three, such as brain spinal cord lesions, and NMO IgG antibody positivity, and brain MRI not consistent with multiple sclerosis. However, in 2015, the International Panel on NMO Diseases revised the criteria and gave these detailed criteria, which Dr. Preeti has already explained. I would just like to say that over here, as she was telling that there are definite criteria for NMO SD without a presence of aquaporin antibodies. So over there, the role of MRI becomes even more important, and we should pay much more attention to the findings of acute optic neuritis, myelitis, imaging of the brainstem, area postrema, which might help us possibly diagnose quite early. And this is again an article, image from an article which tells actually a lot of information about NMO spectrum disorders. It says that where all the aquaporin antigens are present and where all there could be the lesions in a patient with NMOSD. So if we see this slide, it shows that how we can distinguish between MS and NMO on imaging. In MS, there is significant brain lesions, and we can see the white matter involvement, optic nerve involvement, and pericallosal lesions are classical. In the spine, there is involvement of short segments of spinal cord, and CSF shows presence of CSF oligogonal bands. Whereas in NMO, it involves spinal cord and optic nerve. The spinal cord involvement is in form of long segments of involvement, and CSF usually will not show oligogonal bands, but will show polypleocytosis with polymorphonuclear cells. Why it is important to distinguish between NMO and MS? We remember that the pathophysiology is different. There is much more damage in NMO, also leading to incomplete visual recovery. So we need to be more aggressive. The definite treatment is different in the two. And as Dr. Preeti said, some of the drugs like interferon, beta, tisabri, and fingolimod, they can all lead to worsening of the NMO. Therefore, it is very important to distinguish between the two. I'll present the last case over here, which is that of entity that is coming up more and more, especially in the pediatric optic neuritis. This is a 9-year-old female who presented to us with acute onset decrease in vision in left eye, and there was history of recent onset seizures around 2 months prior. At presentation, right eye visual acuity was 20/20 and left eye was counting finger 2 meters, and the left eye there was RAPD. we can see that right eye fundus was normal and left eye showed disc edema. Imaging initially showed few lesions in the left optic nerve, but rest of the brain parenchyma was normal. But after 1 month of initial treatment, the patient presented with decrease in vision in the right eye. And at this time, the RAPD was present in the right eye, disc edema was there in right eye. Rest of the fundus is still unremarkable. And at this point of time, the detailed MRI of the patient showed presence of involvement in both optic nerves. We can see much more marked acute lesion in the coronal images over here in the right optic nerve. And we can see enhancement. Plus, there are multiple lesions in various areas. We can see that there are lesions in the subcortical white matter, and see these are quite big lesions. There is involvement of the optic tract and lesions very close to the brainstem. So this is not a typical finding of MS or NMO. We have to think that this could be something else. And what we think of at this stage is either ADEM, acute disseminated encephalomyelitis, or especially in children, we think of MOG, IgG, optic neuritis. So MOG-related optic neuritis can present in children and young adults. Usually it is bilateral, but can be sequential involvement. There is accelerated response to steroids, but recurrences are very common. And it can also be associated with myelitis and encephalitis, and can have edema-like features on neuroimaging, especially in children. It is also recognized that it's a part of a larger spectrum where optic neuritis, encephalomyelitis, with or without myelitis can occur, and therefore we use the term MONEM to treat spectrum of these findings. And this slide possibly tells and summarizes how we can distinguish between the different associated emulating disorders in the three common entities. MS, which there is unilateral involvement, is much more common. There is involvement of the anterolateral areas of the spinal cord. The lesions are discrete in the spine, and there are white matter lesions in various areas in the brain parenchyma. As compared to that, NMO spectrum disorders will usually have bilateral involvement or a long segment of optic nerve involvement. Chiasm might be involved. There is longitudinally extensive transverse myelitis. The lesions involve the central canal, and there is periependymal lesions which can be seen. The MOG optic neuritis is frequently bilateral but spares the chiasm. There is spinal cord involvement is similar in division as in NMO, but occurs more commonly in the lumbosacral area, and the area postrema involvement can be very frequently seen. Brain parenchyma can have multiple disseminated lesions in MOG optic neuritis. Just briefly telling the experience from India, this is a very good study which is published few years ago from Shankar Netralia, which said that patients who have NMO tended to be actually more commonly to be females. They tended to have bilateral involvement, and recurrences were quite common in these patients. And these patients might also have a common association with ANM positivity. What is important is that patients who were positive for NMO tended to have much less recovery as compared to patients who are having who are seronegative for NMO. So even if there is severe optic neuritis at presentation, patients who are seronegative can improve much more, whereas patients who are seropositive for NMO tend to have worse recovery. And in fact, some of them might duration of visual recovery acute as compared to the presentation in some of them. The MRI lesions, as we discussed before, tend to fall in line with whatever features we have just discussed. Dr. Preeti alluded to this slide about treatment for NMO, so I will not go into much detail about it. So what, as a neuro-ophthalmologist, we should be doing? We should be trying to see that whether the patient falls into a typical idiopathic optic neuritis or an optic neuritis in setting of multiple sclerosis. So what are the clinical features of a typical optic neuritis? The typical optic neuritis patients tend to be young and middle-aged female patients. They tend to have sudden onset unilateral vision loss, might have pain on eye movements and dyschromatopsia. Most commonly, they have associated history of febrile illness, vaccination, or might be known to have MS. Then they respond very well to treatment with ONTT protocol, and we see that the vision loss usually stops progressing after 1 week to 10 days. By second to third week, there is improvement in high contrast visual acuity. By 6 to 8 weeks, there is very good improvement in high contrast visual acuity. In contrast, patients who have atypical neuritis, they tend to fall at extremes of which less than 12 years or more than 50 years. They might have progressive visual loss. There might be lack of pain, or pain might last for a long time. There might be bilateral involvement or recurrent optic neuritis. They might have a steroid dependent course. So as long as you give steroids, they are fine, but as soon as you stop, they tend to recur. They might have concomitant constitutional symptoms like seizures, and there might be severe disc edema. I would like to add this slide where when we should start suspecting NMO in the first episode of optic neuritis, because we saw few cases where it was delayed. And so when we have longitudinal extensive optic neuritis, where we have poor visual recovery, we have prolonged vomitings and hiccups at presentation, chiasmal involvement, simultaneous bilateral involvement, these patients definitely deserve consideration towards NMO at the presentation. And we should pay attention to the fellow eye or coexisting pallor, even in one eye, both eyes. So if there is a presentation with pallor in one eye and disc edema in other eye, it points towards possibly a previous episode, and we should think of possible MS, NMO, MOG in these patients. And if there is an associated hemorrhage as shown here, this points towards MOG optic neuritis. We need to do a workup for both ophthalmological and neurological aspects. We do visual acuity, visual fields, VEP when needed, and do a OCT. And neuroimaging is mandatory. We need to obtain an MRI brain and orbits with contrast, pay special attention to stir and flare sequences, and do MRI spine if there is recurrence, or you have a high suspicion for NMO optic neuritis at presentation. I think I will conclude here by saying that optic neuritis is one of the most common diseases that we see as ophthalmologists as well as neuro-ophthalmologists. Most common etiology is demyelination. MS, NMO, and MOG optic neuritis are the common etiologies that we need to diagnose. Neuroimaging, that is MRI brain and orbits with contrast, is the most important investigation and dictates how do we proceed further. Many patients do have good response to treatment, but NMO and MOG can have recurrences, and NMO especially can have subnormal outcomes. And we do need to consider risk for development of MS where we are thinking of that. With this, I will conclude, and I would like to invite some of you, if you would like to join for an upcoming educational meeting organized by our institute, IPEP. Thank you very much. I will stop here. And any questions are there, I would be happy to take.
Yes, Dr. Virender, thank you very much for that presentation. Just to hold you on that, as people are preparing their questions, could you just talk more about the IPEP? When it's supposed to be starting, and who is eligible, and what exactly it is? Just a few seconds.
IPEP. Yeah. So IPEP is actually a teaching program that we organize at our institute every year. And this year it's a webinar version. The meeting starts coming week, this Sunday. And I can share with you the program and you can share with others. The program starts actually this Sunday and will be there for 1 week. And there are sessions which are planned in the morning and in the evening of Indian Standard Time. So you can all see. All the postgraduates usually benefit a lot by this kind of program because it deals with teaching for all the aspects of ophthalmology as a whole.
Okay, thank you very much. And how much are the charges? Are you in a position to tell us?
Yeah, I think in INR it is 5,000 rupees. How does it translate to USD? I have no idea.
Okay.
I think what is the charge for international delegates? I don't remember, but I can get back to you.
Okay, so you are going to share the link with us, and then we can distribute to the rest of the members.
Yeah, I'll do it with you right now.
Okay, thank you very much. I'll hand over to Dr. Kafula as she introduces the other two panelists. Dr. Kafula, are you there? Okay, I think maybe she's not able to reach us. At this point, I'll introduce Dr. Sela to share with us this presentation. Kindly reserve your questions. I forgot to mention that. Reserve your questions, and then after Dr. Edika, and then we'll have all the questions asked later.
Thanks, Dr. Mumbi. My name is Dr. Deanna Saylor. I'm an assistant professor of neurology at Johns Hopkins University, but I've been based full-time in Zambia for almost the past 3 years, where I've been leading the first neurology postgraduate training program and the first neurology inpatient service in the country at the University Teaching Hospital. And I was asked to talk to you all today about a neurologist's approach to optic neuritis. And so this talk is going to be a bit different. I'm not going to go through any specific cases, but just really take you through the diagnostic approach and the way I think as I approach these patients. I have no significant disclosures related to this talk. So when we think about optic neuritis, I know this has been drilled down in lots of talks. So as you all know, this is really a non-specific term for inflammation of the optic nerve. And there are lots of different things that can cause optic neuropathy. And so it's important to make sure that we are talking about optic neuritis when we talk about this. Once we that this is an inflammation of the optic nerve, we're really starting thinking about typical optic neuritis, which generally refers to idiopathic optic neuritis to multiple sclerosis. These are generally demyelinating lesions. This is isolated, usually unilateral presentation. Sometimes we refer to this as MS optic neuritis, idiopathic demyelinating optic neuritis, or clinically isolated syndrome. And this is really what was studied in the optic neuritis treatment trial. And then we also think about atypical optic neuritis, which are other immune-mediated causes. And then we break that down into those without systemic disease, like Optica and anti-MOG, which we've been talking about, and those that have systemic involvement, such as sarcoidosis or infections like TB. And so when I'm seeing a patient who's coming in with suspected optic neuritis, my first question is this really optic neuritis? And to answer that, I think about how optic neuritis is supposed to present. So generally, optic neuritis presents with pain. The pain is generally described as being dull and either around or behind the eye. It worsens with eye movements, and it often occurs a day or two before the onset of vision loss, or it may occur simultaneously with vision loss. The vision loss typically develops over hours to days and is associated with a loss of color vision, contrast sensitivity, and visual acuity. It's usually central or diffuse. And so to ask about some of these questions, I often like to ask patients whether things that are red actually appear more brown, if they've noticed any changes in the way that red appears. So that's that contrast sensitivity. And then also looking for a relative afferent pupillary defect on exam. The fundus exam should really be either normal or show some optic disc swelling. If I see these red flags, then I'm thinking this might not be optic neuritis. So if it's painless or there is very extreme pain, if the patient has particularly advanced age, if it is very acute onset, like a hyperacute onset that might suggest more of an ischemic lesion, if there's been recent trauma, if there's an altitudinal visual field defect or an abnormal retinal exam, if there's unilateral vision loss without an afferent pupillary defect, if eye movements are abnormal, if there's proptosis, or if someone is immunosuppressed or has poorly controlled diabetes, and these are all red flags that this may not be optic neuritis. So in working these patients up when you're trying to decide if this is optic neuritis or not, in general, all of the patients should have a formal ophthalmologic exam and then an MRI brain and orbits with and without gadolinium. And the purpose of these is largely to exclude alternative diagnoses. If you do ultimately decide that this is not optic neuritis, the question is, did we localize the problem wrong? Is it not the optic nerve, but maybe the eye itself? Or have we found the wrong etiology. So thinking about wrong localization, these are generally problems within the eye itself that generally fall more within the realm of our ophthalmology colleagues than neurology. Or is this the wrong etiology of optic nerve pathology? Could this be an ischemic optic neuropathy or compressive neuropathy? Could it be genetic, such as Leber's? Is there a toxic, metabolic, or nutritional cause? So these are the types of things that I'm thinking about if it's not optic neuritis. But what if it is optic neuritis? The next question for us is this typical optic neuritis or is this atypical optic neuritis? And so how do we differentiate those? So typical optic neuritis tends to present in young adults and also pediatrics, as we've heard. I've put Caucasian in italics here because we'll talk about a bit later that I think the data around that is really skewed. Again, typical optic neuritis tends to be unilateral and isolating. We should have a typical pattern of pain and vision loss, like we just talked about. The fundus exam should be normal or show papilledema. People generally reach their worst level of vision loss within 2 weeks and then begin improving within 3 weeks. You can get a history of Uthoff's phenomenon, which is where the vision loss becomes worse when the patient is overheated. So maybe if they're taking a hot bath or shower, they notice that their vision becomes even worse. Pulfric's effect is where, because of the differential in lighting that's reaching the optic nerve because of the impaired vision in the affected eye, you actually get a false sense of depth perception. History and imaging suggestive of MS obviously would make this typical MS-related optic neuritis, and there should be no evidence of systemic disease. Atypical optic neuritis tends to be in patients that are less than 15 or greater than 40, usually described more commonly in African or Asian descent. It's often bilateral, painless or pain for more than 2 weeks, an atypical fundus exam, severe vision loss, a progression for more than 2 weeks, no improvement within 3 weeks, no steroids, and a history of cancer, signs or symptoms of systemic disease. So if we decide that this is atypical optic neuritis, then our next question is this atypical optic neuritis without systemic disease, at which point we're really thinking neuromyelitis optica, analog-related optic neuritis, chronic relapsing inflammatory optic neuritis or CRION, or more commonly in kids, post-infectious optic neuritis or ADEM. And if there are signs of systemic disease, then we start to think about things like sarcoidosis, connective tissue disease, vasculitides, infections, especially in our setting, ophthalmic syphilis or TB, neoplasms like lymphoma or paraneoplastic syndromes, especially in older adults. But if we're thinking about typical optic neuritis, then a lot of the fundamental knowledge that we know is from the optic neuritis treatment trial, which studied 457 patients with acute optic neuritis. And these patients were randomized to either receive IV methylprednisolone for 3 days, followed by an oral prednisone taper, oral prednisone for 14 days, or placebo. And they were followed for visual function for up to 6 months and their MS risk up to 2 years. Patients were between 18 and 46, and they had to be presenting with their first episode of unilateral optic neuritis. They had to be enrolled within 8 days of the onset of symptoms, and they were excluded if there was clinical evidence of systemic disease. So I think it's worth noting here that patients with bilateral optic neuritis were excluded. So most patients, even though we didn't know about NMO when this trial was conducted, most patients with NMO, or many patients with NMO would have been excluded. When you look at who was included here, these were primarily women, primarily white women, primarily youngish in their early 30s. And you can see that most of them had mildly impaired vision. So more than half had vision that was better than 20/200. And there were few that had vision that was so severe that they had only finger counting or minimal light perception. So what did we learn from this trial that was done almost 20 years ago? So we know that IV methylprednisolone increased speed of visual recovery. There may have been a worse outcome in the oral prednisolone group, but at 6 months, what we saw was that there was no significant difference in visual acuity between the groups. So it seemed that IV methylprednisolone increased the speed at which vision recovered, but didn't change visual outcomes. although the methylprednisolone group did maintain better visual fields, contrast sensitivity, and color vision, although visual acuity itself was not significantly different. And overall visual recovery was good. So at 6 months, only 5 to 7% of their participants had a visual acuity worse than 20/50, but 2/3 of those who presented with light perception only did not improve to that extent. And generally improvement began by 3 to 4 weeks after onset of symptoms. But what I think has been interesting to come out of this is they did a 15-year follow-up of patients in this group, and they looked at the association between the brain MRI at their baseline and their 15-year risk of MS. And what they found is that if at the time of your initial optic neuritis, you have a brain MRI and there are no lesions on that MRI, then you actually still have a 25% chance, a 1 in 4 chance of developing multiple sclerosis over the next 15 years. But if at the time of that initial optic neuritis, you have 1 or more lesions on your MRI, then you have a 72% chance, a 3 in 4 chance of going on to meet diagnostic criteria for multiple sclerosis in the next 15 years. And the more lesions you have, the higher your risk. So again, if you're kind of landing in this typical optic neuritis category, then you make sure the patients are getting a formal ophthalmologic exam, the MRI of the brain and orbits that's going to help rule out other causes, but also stratify the MS risk. You're going to probably also want to check the aquaporin for antibodies, particularly if this seems to be more severe or maybe more atypical, or if the MRI is normal or has atypical lesions for MS. There are some additional studies you can think about if you're worried about atypical optic neuritis. Acute treatment, again, is going to be high-dose IV methylprednisolone for 3 to 5 days. We usually, in common practice, don't taper for these patients, although the optic neuritis treatment trial would suggest that you need to complete a 2-week course of a taper. And then you're going to follow these patients up within 2 to 3 weeks. If vision loss is severe or fails to improve, or if you notice atypical features, then you want to switch to the atypical diagnostic pathway and consider plasma exchange for the next phase of treatment. Based on your MRI findings, you're also going to want to think about MS risk and whether or not patients should be started on MS therapy. If in this diagnostic pathway you end up in the atypical pathway, you're really going to do the same, except you're going to do some extra tests. You're going to look for signs of systemic disease with an expanded laboratory investigations. You're going to think about CSF studies to look for infectious causes, especially TB in our setting. You may think about investigating for an underlying malignancy or a paraneoplastic process as well. Your acute treatment after you rule out infection and lymphoma is going to be the same, but these patients are probably going to need a longer and slower prednisolone taper, but have a low threshold for initiating plasma exchange if that's available in your setting, if there's a concern for NMO. And follow-up, you're really going to be thinking about the need for long-term immunosuppression that's going to be specific to the etiology of this optic neuritis. And so I know we've been focusing on NMO, but I did want to just talk about multiple sclerosis for a minute. So this is a progressive neurologic disease of the central nervous system that affects the brain, optic nerves, and spinal cord. It's characterized by these recurrent relapses or attacks. And eventually, after enough attacks, the recovery is incomplete and disability accrues. And in the United States, it's the leading cause of non-traumatic disability in adults. The diagnostic criteria is based on clinical presentation, the MRI findings, and the CSF findings. And we've already talked about these kind of classic periventricular lesions. And we've talked a lot about NMO and how this was previously considered a subtype of MS, but with the identification of aquaporin 4 antibodies about 16 years ago, we were able to definitively say that this was a different disorder. And then we've also talked about MOG syndromes here. But I just want to touch on MS for a bit. So this usually affects young adults between 20 and 50 years old. Women are much more likely men, and in cases where the incidence and prevalence are higher with increasing distance from the equator. And the dogma is that there's no MS in sub-Saharan Africa. But when you look at where that dogma comes from, the data is really lacking. Prior reports for MS have mostly been single center case series. There was one multi-center case series comparing the effect of race on MS incidence and prevalence from South Africa that took place during apartheid. So you can imagine that Black South Africans did not have equal access to neurologists at that time. And if you look, the places in the world that have the lowest reported prevalence of MS also have the lowest prevalence of neurologists. And so I think my experience in Zambia suggests that MS does exist. So we're diagnosing 1 patient per month with MS at our outpatient neurology clinic, and an additional 1 to 2 patients per month with NMO, either from the outpatient clinic or the inpatient wards. And what I've noticed is that every single Zambian that I've diagnosed with MS has had significant disability at the time of their initial visit to the neurology clinic. All of them are either wheelchair dependent or at least required ambulatory aids. They reported a sense of isolation with the diagnosis. And all of them were in either the upper middle class or upper class of socioeconomic status. All had been misdiagnosed. Several were told they had functional neurologic disorders. Stroke was the second most common diagnosis. All had seen at least 3 other providers before they were referred to us. And so I really think that we're just seeing the tip of the iceberg of MS patients here. I don't think MS only affects wealthy Zambians. I think they're just the only ones who have the means and ability to keep pushing through the healthcare system to get a different answer. And so I think it's really important that we raise awareness amongst providers that are likely to see these conditions so that we can get these patients diagnosed. And so I think what I hope my take-home message from this is that all patients with suspected idiopathic and presumed inflammatory optic neuritis should be evaluated by both ophthalmologists and neurologists, with the goal to determine if there's a primary neurologic disorder that puts the patient at risk for recurrent attacks of optic neuritis or the development of other neurologic symptoms. And it's important because early evaluation and initiation of disease-modifying therapy in these patients can prevent the accumulation of disability and improve outcomes. And it's also important to note that even in our resource-limited setting here in Zambia, we do have treatment options available for virtually all of these underlying conditions if we make the correct diagnosis. So I'm always available by WhatsApp, phone call, SMS, or email. If anybody is seeing these patients and needs to know how to refer them to us. We are the only neurology clinic in Zambia now at ETH, so patients do unfortunately have to travel to see us, but I think it's really important that we make this diagnosis and start treatment. I just want to acknowledge my funders, and I'll be happy to take any questions at the end.
Thank you very much. I think Dr. Kafula is in. I'll allow Dr. Kafula to take over.
Thank you very much, Dr. Saylor, for that wonderful presentation. It has definitely changed a lot of our perspective of optic neuritis. Without delaying much, we're going to move on to our next presentation by Dr. Elika. If she's here, she can go ahead and start sharing her screen. Dr. Elika, as I mentioned earlier, is an assistant professor of imaging science. So she's going to take us through the neuroimaging aspect of patients that come in with optic neuritis.
Hi, can you all see my screen? Can you see my screen?
Yes, Dr. Elika, we can see it.
Oh, okay, perfect. So I was told to talk on optic neuritis, and thank you so much for this opportunity. And I learned a lot. And I think my work is going to be a little bit easier now that I'm following Preeti and Dr. Sachdeva and Dr. Saylor. So they made my work a little bit easier. So I'm going to be talking on the imaging perspective of optic neuritis. I don't have any disclosures. And just before I start talking on the optic nerve, as a radiologist, we always pay attention to anatomy. So knowing the anatomy of the optic nerve is approximately 50 millimeters long, and it's divided into various segments. You have an intraocular segment, which is the segment which emerges through the scleral opening. Then you have the intraorbital segment, which is the longest segment, and there's communication of the perioptic CSF spaces with the suprasellar cistern. Then you have the intracanalicular segment, which passes through the bony optic canal.
May I interrupt you, Dr. Elika?
Yes.
I think the image, the slides being shown a little bit, they are split and then they are small. I'm not sure exactly whether it has to do with screen sharing.
What are you seeing?
So seeing split images, and then yeah, we are seeing quite small image. I don't know whether the rest of the participants are seeing that, or is it just my laptop?
No, I think you have to go to the adjust the settings. Display settings are there. We have to duplicate the settings, then it will come.
No, actually, I do it the Zoom all the time. I don't know why this is. Give me 1 second. Let
In
me
the
just
PowerPoint, I think it is still not gone into the full slideshow mode.
Give me 1 second.
I think we're seeing the presenter view.
Oh, you're seeing the presenter view. Maybe I'm
view.
I'm
Yes.
showing the wrong screen. Give me 1 second. Let me just do that. I'm trying to see where I need to. Let's do this. No, that's not the one I want. Optic neuritis. And let me see if I do stop share and I start sharing again. Share screen. So I should be sharing screen 1. Okay. Let's see. What about now?
Yeah, perfect.
Perfect. So I was talking about the intracanalicular segment, which actually passes through the bony optic canal along with the ophthalmic artery. And then the intracranial segment is further subdivided into the prechiasmatic segment, which is the portion of the nerve in the suprasellar cistern, but just before the optic chiasm. The optic chiasm is the portion where the nasal fibers actually cross over, whereas the temporal fibers go uncrossed and go to the lateral geniculate body. And then the optic radiations extend from the lateral geniculate body and go to the striate cortex in the occipital lobes. The importance of knowing some of this anatomy is also to know how the masked lesions will affect the optic chiasm. So in around 80% of patients, the optic chiasm is actually located above the cella. So if you have a pituitary masked lesion, it compresses on the cella and gives you a bitemporal heminopsia. And in around 10% of patients, the optic chiasm is prefixed, so it lies above the tuberculum cella. So if you have a pituitary mass which is kind of going straight up, it may not compress on the optic nerve. And in another 10% of patients, you have what is called a postfixed chiasm, where the chiasm is actually above the dorsum cellae, in which case also, like I said, the optic chiasm doesn't get compressed unless there is a retrocellar extension of that pituitary mass. So how do you image the optic nerve? MRI is the modality of choice to evaluate the optic pathway. And what we tell patients is that when we ask them to, when they lie in the scanner, we ask them to avoid eye movement. So we ask them to actually fixate at a point. Also, if they are female patients, we ask them to refrain from applying mascara because some of those cosmetics can cause artifacts during scan. When we image the orbits, we use a smaller field of view. And we use thinner sections because we're looking at small structures. So we do thin sections, high resolution axial and coronal T1 and T2 weighted imaging. When we're doing T2 weighted imaging, we want to do fat saturation, or we can use what is called a specialized form of imaging, which is called STIR, where you get fat suppression. Again, you have to do the thin sections both in the axial and coronal weighted images. And in some cases, some centers do use oblique sagittal images to view the entirety of the nerve. We don't at our center, but that's an option. And then you want to also do high resolution post-contrast axial and coronal T1 weighted images. And when you do the post-contrast imaging for the radiology trainees, you need to do them with fat suppression. When you're doing the pre-contrast imaging, it's without fat suppression because you want to see how the nerve affects the surrounding fat. But when you're doing post-contrast imaging, you want to suppress the fat so that the enhancement kind of, strikes, contrast builds up. And then we also do axial or coronal diffusion weighted imaging. And now in cases of, especially when you're suspecting demyelinating lesions, which we're going to be talking about today, you also need to do post-contrast imaging of the entire brain. And then we do what is called 3D FLAIR imaging, which is a volumetric T2 FLAIR imaging of the entire brain, which will help you pick up some of these demyelinating lesions associated with NMO, MOG, as well as MS. And I'll show you examples of each of them. So that's on the imaging of the optic nerve. The next thing that I want to show you is how the optic nerve actually looks on imaging. So the optic nerve looks iso-intense to the cerebral white matter on both T1 and T2 weighted images. So this is an axial T2 weighted image with fat saturation. You can see the fat in the orbit is all suppressed. You can see the nerve beautifully, and the nerve has the same signal intensity as the cerebral white matter. And on the T1 also the same thing, the nerve has the same intensity as the cerebral white matter. Also the optic, you also study the optic nerve, the nerve sheath, which is actually surrounding the optic nerve and contains the PIA, the CSF, arachnoid and dura, because the optic nerve is considered to be an extension of the brain. So it has all the layers of the surrounding structures of the brain too. So coming to optic neuritis, and I know Dr. Saylor kind of made this easy for me. So there are two forms. You have the major category is inflammatory, non-infectious, and infectious. And in the inflammatory, non-infectious, the ones which are not associated with any systemic disease have isolated optic neuritis, which is a part of the, which may be a part of the clinic. Isolated neuritis, sclerosis, NMO, anti-MOG, as well as ADEM. And then I'll be not today. What I'm going to focus is on these conditions. We're not going to be talking about the infectious causes of optic neuritis. So coming to the inflammatory / demyelinating optic neuritis, like I said, it's associated with all these different conditions. And like Dr. Saylor mentioned, it's further subdivided into typical and atypical, and she's already gone over it. So I just don't want to repeat it. And I think Dr. Sachdeva also went over it. So I'll skip that. I'll just go over some of the findings. So typical optic neuritis is an autoimmune process triggered by infection, systemic disease, or other stressors. But classically, it's got an acute to subacute onset. Typically a young adult patient, less than 45 years of age. Typically, there's unilateral loss of visual acuity, and there is reduced contrast and color vision, which is out of proportion to the loss of visual acuity. They also get this exacerbation of symptoms with increased body temperature that Dr. Saylor alluded to, Uthoff's phenomenon. Most of the times, the optic nerve head is normal. There's very mild periphlebitis or venous sheathing that the ophthalmologist sees. And then there's spontaneous visual improvement in more than 90% of the patients starting within 2 to 3 weeks, regardless of the treatment. And overall, the other thing that Dr. Saylor alluded to was also the optic neuritis treatment trial, where they said that almost 50% of clinically isolated cases of ON go on to develop a second MS-defining episode by 15 years. And the risk of developing is 25% if the baseline MR is normal, and it's higher when the baseline MR has one or more brain lesions, which are typical for MS. So we'll just look at what how typical optic neuritis looks like on imaging. So you see enlarged T2 hyperintense. So this is a T2 weighted image. So you see an enlarged T2 hyperintense and enhancing optic nerve. So this is the normal optic nerve. You see that this optic nerve is enhancing. The optic nerve sheath does not enhance. And most of the optic nerve enhancement in a typical optic neuritis involves the anterior portion of the anterior orbital portion of the optic nerve. And like all of the speakers who spoke ahead of me, optic neuritis, and I just want to reiterate this to all the listeners, optic neuritis is a clinical diagnosis. Neuroimaging is critical to assess for demyelinating brain lesions, which are suggestive of MS. And we talked about how what the significance was based on the optic neuritis treatment trial. So here's an example just to show you how this, translates to actual imaging. So here's a patient, a 45-year-old presenting with right eye pain and vision loss. And you can see that the right optic nerve is enlarged and enhancing. This is the T2 and this is the post-contrast T1. But when you start looking at this patient's flare, this is a 3D flare image that we obtained through the brain. And you can see that there are these multiple periventricular lesions, and some are also almost deep white matter lesions. I'm next going to show you a contrast enhanced scan, and you can see several of these lesions are actually enhancing. So this tells you that this patient has, even though this patient is presented with optic neuritis, she has several other lesions in the brain which are active demyelinating lesions, given the fact that they are enhancing, which are asymptomatic at this point. So the importance of imaging is actually to pick up these lesions and diagnose these patients as multiple sclerosis, especially in this kind of a very typical setup where the lesions are periventricular. So this is a good segue to talk about what the characteristic MS lesions look like in the brain. And this is less going to be a repetition, because a lot of speakers ahead of me also said that. So typically the lesions, MS lesions in the brain are T2 hyperintense. They're typically ovoid. They're located in the periventricular so periventricular lesions are typically in that kind of Dawson finger pattern. You also get lesions in the juxtacortical or cortical locations. And as we know, as imaging is getting better, we know that a lot of MS lesions are also in the cortex. So we don't call it juxtacortical, we call it cortical/juxtacortical. You also see lesions in the infratentorial brain parenchyma. It involves the brainstem as well as the cerebellum. And in the brainstem, you can have typical lesions which are along the intrapontine course of the trigeminal nerve. So you have a lesion here. This is where the trigeminal nerve comes out. So you have lesions characteristically along the course of the nerve in the brain. Also, acute lesions enhance with gadolinium, while older lesions don't. So you have an example here, which is a post-contrast T1 weighted image. You can see enhancing lesions, and there are non-enhancing lesions. So this allows you a radiographic dissemination in time, telling you there are lesions which are active and inactive. So that's what MS looks like in the brain. What are the characteristic MS lesions in the spine? Again, these lesions in the spine are short length lesions. They involve less than 2 vertebral segments. There is preferential involvement of the cervical cord. Again, these lesions are T2 hyperintense. When we look at them on the axial plane, they are ovoid, almost wedge-shaped lesions, and they're typically located along the periphery of the cord. So here's an example on a T2 weighted image where you can see it involves the lateral portion of the cord. Here's another example involving the right lateral portion of the cord. And we also do what is called the GRE sequences, which very nicely show these MS demyelinating lesions. So this H-shaped structure is actually the central gray matter, but you can see the lesions involving the lateral and dorsal columns. So the most commonly affected columns are the dorsal and lateral white matter tracts. So this is what MS looks like, lesions look like in the spine. I'm just going to say a little, I'm just going to talk about the McDonald criteria in relation to optic neuritis. So McDonald criteria outlines the clinical, radiographic, and laboratory evidence that is required to prove that a demyelinating disease is disseminated in space and times. The optic nerve is not considered a typical lesion location for MS, while it has been suggested that MR optic nerve enhancement should qualify as radiographic evidence for dissemination in space. The 2017 McDonald criteria rejected that idea. Therefore, if a patient, according to the McDonald criteria, if a patient has typical optic neuritis and a normal brain MR, they do not qualify as MS. Similarly, if a patient has typical optic neuritis and 1 typical MS lesions on MR, that also does not meet McDonald criteria for MS because the optic neuritis lesion is not considered as dissemination in space. So basically, optic neuritis is not a part of the McDonald criteria for MS. That's what I wanted to highlight on this slide. And this is actually a collage of how MS looks in the brain, spine, and optic nerves. So classically, it involves the anterior portion or the anterior portions of the orbital portions of the optic nerves. You get these very typical lesions along the callosoceptal septal region of the corpus callosum, and then the classic Dawson's fingers that we talked about. And then you get these infratentorial lesions, and like we talked, lesions along the intrapontine portion of the 5th cranial nerve. And then we talked about the dissemination in time, where there are enhancing as well as non-enhancing lesions. So that tells you, again, radiographic dissemination and talking about radiographic dissemination in time. And then classic lesions in the cord are short segment lesions and typically not longitudinally or transversely extensive, typically involving the dorsal and dorsolateral portions of the cord. And again, if you do the GRE sequences, some of these lesions are very well seen. Okay, now coming to atypical optic neuritis. This is optic neuritis from any other cause other than MS. So this includes NMO spectrum disorder, the myelin, the MOG-associated optic neuritis, ADEM and infectious optic neuritis, and various other optic neuritis associated with systemic diseases. And they talked, several speakers have spoken about it, sarcoidosis and such. And I won't be talking about that. I'm just going to be concentrating on the NMO spectrum and myelin oligodendrocyte associated optic neuritis. So we already went through this again, the atypical
Excuse
features.
me, Dr. Elika.
Yes.
Just a reminder, you have under 2 minutes.
I have what?
2 minutes of your time. You have under 2 minutes of your time, Dr. Elika.
Oh my God, then I better speed up. I have a lot to show. Okay. So let's go to neuromyelitis optica spectrum disorder. This is a severe inflammatory demyelinating disorder, which is distinct from MS. So what it does is that the NMO spectrum disorder is basically, it's an astrocytopathy. Basically what you see is these antibodies against the aquaporin 4 channels, which are populated along the astrocytic foot processes. And this antigen antibody reaction basically causes fixes complement, which amplifies the astrocytic injury. And when the astrocyte dies, it releases GFAP, which is glial fibril acidic protein. And later, initially, so you can see very clearly, initially the myelin is preserved in NMO. So it's basically an astrocytopathy. So that is a big, difference that I wanted to highlight. The other thing, I'm going to skip. This has been shown by several of the speakers. So what happens is that initially it is basically an astrocytopathy. The astrocyte dies, and then you also get when the macrophages come in, you also get myelin loss as well as death of the oligodendrocyte. So this is basically just showing you the timeline for NMO. So basically, this is again from the paper that Dr. Sachdeva also alluded to. So this is a very good paper for some of the, whoever wants to read it. It's a very nice article on NMO spectrum disorder. So basically, the term NMOSD was actually introduced in 2015, and they already, I won't be talking about much about this, the new criteria for NMOSD. So just to show you this again, a lot of the speakers have spoken about this. I just want to kind of just bring to your attention the core clinical characteristics. Basically, it is optic neuritis, acute myelitis, and the area postrema syndrome. And a lot of the speakers have spoken to about this. If you have, where is that slide? So if you're IgG positive, aquaporin 4 IgG positive, you just need one core clinical characteristic to make a diagnosis of NMOSD. Whereas if you're aquaporin 4 IgG negative, or if you're unknown status, then you need two core clinical characteristics, and you must also fulfill additional MR requirements. So I'll just go over quickly some of the MR findings in NMOSD. So the optic nerve findings, optic nerve neuritis is a core clinical syndrome in optic neuritis. Typically, the optic nerve involvement is bilateral and longitudinally extensive. It usually affects more than half the length of the optic nerve, and there's preferential involvement of the posterior optic pathway. So basically the intracranial portion of the optic, especially the optic chiasm. In the acute phase, the optic nerve is thickened and swollen. So here is an example where there's more posterior involvement. So this is a patient which has involvement of the intracanalicular portion of the optic nerve. And as I go more posteriorly, you can see there's also involvement of the intracranial portions of the optic nerve. In the chronic phase, what happens is that the optic nerve atrophies and you may have variable T2 hyperintensity. So that's how it looks like. And this is another example, very nice example, showing you longitudinally extensive involvement. So here's a patient who presented with right-sided visual loss. And you can see that this right optic nerve is very thickened. On the flare, it's bright and it enhances, and it's involving more than 50% of the length of the intraorbital segment of the optic nerve. On the coronal images, again, showing you the bright nerve as well as the enhancement, and you can see the enhancement goes posteriorly to involve even the intracanalicular portion. So this is a longitudinally extensive optic neuritis, which is also seen with the NMOSD. The typical brain findings, Dr. Sachdeva has already spoken about this. Very typical periependymal regions are involved, and this is the classic location where the aquaporin 4 channels are very densely populated. So that's why you see them over there. And then you when you give contrast, you basically see this very patchy and blurred margins of enhancement. So this again is from that paper, and Dr. Sachdeva already talked to you about it. So basically you see the ependymal surface of the corpus callosum that is involved. You see involvement along the ependymal surface of the lateral ventricles, along the periependymal surface of the third ventricle. The periaqueductal region, here's involvement of the hypothalamus. Here's involvement around the fourth ventricle, and this is the area postrema, which is basically the dorsal portion of the medulla, not the pons, the medulla, that is the area postrema. So just showing you very quickly the diencephalic involvement, you basically see lesions around the third ventricle with involvement of the hypothalamus, thalamus, and the periaqueductal region. So this is a case I saw here, very similar to what I showed you before, enhancement, enlargement, and enhancement of the intracanalicular and intracranial portions of the optic nerve. And these very characteristic lesions which are surrounding the third ventricle and involving the hypothalamus and show this kind of enhancement, very typical locations for NMOSD. So this is one subtype. You also see area postrema syndrome. So here you see involvement of the dorsal medulla. You can also see, and like we talked about, patients present with intractable nausea, vomiting, and hiccups. You also see, when there is area postrema involvement, you can also see that these lesions can extend down into the cervical cord, and you get this longitudinally extensive transverse myelitis. Occasionally, you can see corticospinal tract involvement. I myself have not seen one. I've taken this from the literature. The actual cause of this is not known. This is not an area where we normally see aquaporin 4 channels, but it is seen in around 23 to 44% of NMOSD patients. And it's this, when it affects the posterior limb of the internal capsule, it causes this very typical trident-shaped appearance where edema extends to into the plic, the subinsular white matter, as well as the temporal lobe, giving you that kind of trident appearance. And this is a collage of NMOSD showing you the area postrema involvement, the dorsal brainstem involvement. Again, the lesions enhance, and you can see very faint but very cloudy kind of faint enhancement. This is a patient who was proven to have NMO spectrum disorder, and these lesions also showed restricted diffusion on the DWI images. The spinal cord findings, again, we alluded to extensive lesions involving more than 3 contiguous vertebral segments. So you can see 1, 2, 3. So this goes way beyond that. It affects the, these lesions enhance pretty intensely. Again, the central gray matter is involved. You see that? So because the aquaporin 4 channels are surrounding the central canal in the cord, so you see extensive involvement of the more involvement of the central portion of the cord, and more than, it's also a transversely extensive myelitis. So there's involvement of more than 50% of the cord area, and it classically tends to involve the cervicothoracic segments. And in the acute phase, what you see is basically, like I showed you, you see cord swelling. And then in the subacute phase, the cord swelling has decreased. And in the chronic phase, what you see is cord atrophy. Sometimes you may also see short segment lesions. And even when you see short segment lesions in NMOSD, they're usually longer than the lesions that you see with MS. MS lesions are usually much shorter. And again, even when they are short segment lesions, they're always centrally located, and they involve more than 50% of the cross-sectional area of the cord. So those are important pearls to remember. This patient also showed that kind of very classic cloud-like enhancement that I talked about. This is another patient, again, showing you multiple short segment areas of involvement, and then the enhancement within those lesions. Neuroimaging has got an important role in both the diagnosis as well as management of NMO, because it helps us in differentiating NMO from MS, which is very critical because early and aggressive immunosuppression is required to prevent or reduce severe disability in NMO, and several speakers have alluded to that. And the routine imaging surveillance is also useful to monitor some of the complications of immunosuppressive therapy. So this is a collage, again, showing you the involvement of the diencephalon, giving you the diencephalic syndrome. Here's the area postrema involvement. Here's the longitudinally extensive involvement of the optic nerve with involvement of the intracanalicular and the intracranial portions of the optic nerve. Longitudinally extensive myelitis, transversely extensive myelitis, and occasionally you can see this corticospinal tract involvement, which is a characteristic appearance when you see it in the posterior limb of the internal capsule. And finally, I just need 2 minutes. I'll quickly go over this MOG-associated demyelination. So this is a new clinical entity, and which is very distinct from MS and NMO spectrum disorder. 40% of ADEM is MOG antibody positive. These patients are younger, and classically the acronym that has been described is this MONEM. So it is basically MOG-associated optic neuritis, myelitis, and encephalitis. And what I want to say over here is that it also includes ADEM, which is MOG positive, as well as the aquaporin 4 negative NMO spectrum disorders. So it is a monophasic or recurrent disease. There is less tissue injury than NMOSD, and what MOG-related demyelination does is basically it is an oligodendrocytopathy. So here what happens is that you get antibodies to the MOG protein, which is on the surface of the oligodendrocyte, and then what happens is that there is these antibodies promote demyelination, and then you get release of the myelin basic protein. But you can see here, this is basically an oligodendrocytopathy, whereas NMO spectrum disorder is an astrocytopathy, and they're two completely different entities. So this is the timeline for MOGAD. So initially in 1987, there were initial reports about the MOG antibody. Then in the 2011s, the cell-based assays led to more confident detection of the MOG antibodies. And in 2018, we know that this is a distinct demyelinating entity separate from MS and NMOSD. So what do you see in the optic nerves? There's bilateral involvement, but unlike the NMOSD, there's more anterior involvement of the nerve. The chiasm is typically not involved like we've seen in the NMOSD. So here's an example. You see thickened and hyperintense optic nerves, again on the flare. Typically also what you see is, let me just scroll through this one. The optic nerve head swelling, very classic, retrobulbar involvement. And then you see this perineural enhancement. So here in this patient, there is enlarged enhancement of the nerve. There's enhancement of the nerve, but you're also seeing this perineural enhancement, and you get this kind of inflammation surrounding the nerve. So you get perineuritis, or the involvement of the optic nerve sheath, very classically with MOG. This is another patient again showing you bilateral optic nerve involvement and enhancement. It's involving the anterior portions of the optic nerves. The intracanalicular portions are involved, but the optic chiasm is spared. Again on T2 and flare showing you the hyperintensity, and then the enhancement of the nerves as well as the perineural enhancement, which is very classic for MOG. Another patient again showing you the thick nerve, again the perineural enhancement, and look at that inflammation around the optic nerve sheath. That's very classic for MOG. This patient also turned out to be MOG positive. And then finally the showing you the brain findings. Brain findings look very much like ADEM. You see involvement typically of the deep gray matter, as well as infratentorially you see involvement of the brainstem and the cerebellar peduncles. And then when you see involvement of the, you get these kind of lesions. These lesions, especially in kids, are much larger, more in number, and poorly demarcated. So here's an example that I saw. So this patient presented with optic neuritis, and this patient also had lesions in the middle cerebellar peduncles, in the deep gray nuclei, also in the white matter. And then there were these short segment lesions in the cord. So these lesions look almost like ADEM, but they are very characteristic in appearance. So something to think about. And then finally coming to the spine findings, classically the most common thing that you see with MOG is the involvement of the conus medullaris. So it usually involves the lower portion of the cord. You do see longitudinally extensive lesions too. They're more common in children, but you can also see short segment involvement, usually more in adults. So I'll show you an example. This is a patient I saw with optic neuritis. This patient has a short segment lesion in the conus medullaris. Again, these lesions are also transversely extensive, so they involve more than 50% of the cord diameter. This one didn't show much enhancement, or very little or cloud-like enhancement, if any. And this is another patient, the one which I showed you with the bilateral optic nerve involvement. This was more longitudinally extensive. This involved the cervical cord, and it showed that kind of cloud-like enhancement, which you see both with NMOSD and with MOG. This is another patient I saw who also had optic neuritis. This patient was a young patient, had multiple long segment lesions involving the cord with very patchy kind of enhancement. So you can get both a long segment as well as short segment, but classically what the literature says is that it's the involvement of the conus, which is very specific for the MOG associated disease. So just, I don't have much time, right? Do I? Do I have a few minutes? I'm sorry?
Dr. Elika, you have, if you can conclude in the next 2 minutes, that would be very wonderful.
Okay. So basically, I just want to say that optic neuritis is more common in optic neuritis is more common in MOG and NMO. Bilateral optic neuritis is again more common in MOG. Myelitis is seen more commonly with NMO and MOG compared to MS. Brainstem encephalitis is more common with MOG, and you see coexisting autoimmune disease, which a lot of speakers alluded to, more commonly with NMO. When you look at the spinal lesions, the longitudinally extensive lesions are more common with NMO, whereas with MOG you can see both longitudinally extensive as well as the short lesions, and with MS you basically see those shorter lesions. I think I'll end here. I think Dr. Sachdeva has already gone over this, and I think I've shown more than enough clinical kind of examples to show you the difference. And I think Dr. Sachdeva talked about this, so I won't kind of go there. So I'll just stop there.
Thank you very much, Dr. Elika. We'll go on to see if we have any questions at this point. Christabel, any questions for the faculty?
Yes, Dr. Nkole, we do have a number of questions. We have about 3 questions, although one of them is for Dr. Mwale. So should I just read the ones for the faculty?
May I just interrupt you briefly, Dr. Christabel? Dr. Virender Sachdeva's, it's quite late in India, so if there are any questions directed to him, maybe we can allow a few questions and then afterwards allow him to leave. And thereafter we can have questions for the other presenters.
Okay.
Or any concluding remarks, Dr. Sachdeva?
No, Dr. Can you hear me?
Yeah, yes, we can hear you.
Okay. I think it was excellent webinar, and it was very, very, informative for me to hear from Dr. Selika's talk. She showed wonderful images of all the patients. She has a wonderful collection, and I think all of us learned a lot from this session. And as we all understand that this disease is becoming more and more important for us to recognize that we have to subclassify optic neuritis in setting of what disease is the message that all of us should keep in our mind and try to subclassify that. That would help us a lot. That's all I would like to say. We have to team up with neurologists, neuroimmunologists, and neuroradiologists. That team is very much needed.
Thank you. Any questions, Dr. Christabel? I think you can take over.
Thank you very much once again, everyone.
Yeah, we appreciate your time, Dr. Sachdeva. I think we call upon you next time when we need you.
Sure, I'll be happy to participate. Thank you.
Thank you.
Dr. Mumbi, there's a question. It's open. I don't know who it's directed to. It says, should we order MRI spinal cord in all cases of neuritis, or are there specific indications for us to order the MRI?
Yeah, can I direct this question to Dr. Stella?
Sure. I would say that it depends on who's asking. I think if it's an ophthalmologist, this is a point where the neurologist would be a really good partner to help decide this. As a neurologist, I don't order an MRI spine in everyone. So in patients with NMO or anti-MOX syndrome, they rarely have silent myelitis. I mean, they usually have clinically very apparent attacks of myelitis. And so you're unlikely to find a myelitis that hasn't been clinically apparent in them. I do sometimes order an MRI of the spine in patients in whom I'm suspecting MS. And that really helps for a couple of ways. If they have a sort of intermediate brain MRI that is somewhat typical of MS, but not completely, if I find typical spine lesions, then that can help to confirm the diagnosis. In a setting where I have lots of different disease-modifying therapies available to me, the burden of spinal cord lesions is a good predictor of the severity of the disease course for an individual, and so it might help guide the type of therapy that I would start them on. So it's definitely not indicated in all patients and should be considered on a case-by-case basis.
Thank you, Dr. Sela, for that answer. Dr. Mumbi, there are 2 more questions for Dr. Mwale.
Yes, please.
Dr. Mwale, there's a question for you concerning the case that you presented. Could the vision in the right eye have been saved?
Thank you for that question. I think the vision in the right eye would have been saved if the diagnosis was made earlier and the right treatment plan was started. But the diagnosis came in way later. By the time the patient was going to Lusaka, he had already lost his vision in the right eye because the diagnosis was missed. And then this was a first-year resident who saw this patient, and we usually wake up our patients before starting them on high-dose steroid. So the patient went home and only came back a month later. By then, so much damage had been done. He didn't know the relevance of the investigations we were requesting. So treatment was started late, and the patient ended up losing their vision. But yes, it could have been saved if the treatment was started early and the diagnosis made.
Okay, thank you for that. There's another question. Why didn't you do a plasma exchange? It might have improved the vision.
Oh, well, we don't do that here. Like I said, the diagnosis was not made until it was too late. Plus, we do not do it here. I don't know about UTH.
Plasma exchange is very difficult to organize even at UTH. There's either the machine doesn't have all the parts or the albumin isn't available. So it's just very logistically difficult to organize. But in a setting where you have plasma exchange available to you, there's even an argument for beginning with plasma exchange concurrently with IV methylprednisolone in patients who are known to have neuromyelitis optica and are presenting with severe symptoms.
Thank you so much. Otherwise, those are the only questions that are available at the moment, Dr. Mumbi.
Thank you. Can I hand over this to Dr. Mwansa? Dr. Mwansa, are you there? Okay, as Dr. Mwansa is
Yes,
coming.
I am.
Yes, thank you. Please, the floor is all yours.
All right. Thank you very much for this wonderful interaction. I think it's been very educational, informative, and we just had the best selection of presenters to just deliver this message. So I would like to thank you all and for your participation, attendance. Please hang in there. We are almost done with this webinar. Let's stay and listen to the last part of the presentation. At this point, I'd like to call upon Dr. Pramod Mane, who's MD and Director, Medical Affairs, Mega Life Sciences, a private limited company. He'll be sharing a new product that Mega We Care is going to launch today. So let's pay attention and hear how best we can support our patients, even as we do everything, the investigations. We know that there's a medical part that, they need medications. So at this moment, I'll call upon Dr. Pramod to take the floor. Thank you very much.
Yeah, thank you. Good evening to all. Let me share my screen. Is my screen visible? Slides?
Yes, it is. Yes,
Hello?
it is,
Yeah.
Doctor.
Okay, yeah. So once again, good evening to all. It's my pleasure actually to be a part of this discussion. At the outset, let me thank Zambia Ophthalmological Society for giving Mega this opportunity. I'm going to speak on updates on antioxidants in eye health and diseases, especially focusing on lutein, its role in AMD, then cataract, then diabetic retinopathy, then also digital eye strain, and also coming to another antioxidant and anti-inflammatory phytoextract, bilberry, and then coming to profile of eye care. That is the new product that we are making available in Zambia. So as we know, this lutein is from a xanthophyll group of carotenoids. And as we know, carotenoids are the pigments which we find in the plants. And basically, they are implicated in plants for the protection of the plants itself. And human do need these carotenoids, or basically the in terms of the antioxidants uh, for various physiological functions and the health. So lutein is from the xanthophyll group, and which needs to be obtained through diet, or if diet is deficient, then through supplements. If we look at these key xanthophylls which are there in the macula, as we know, this lutein, zeaxanthin, and mesozeaxanthin. These are the isomers basically, and they differ from beta carotene or lycopene in terms of the hydroxyl ring which is there at the end. And if we look at the differentiation in between lutein and zeaxanthin itself, it is in terms of the double bond which is there, the placing of the double bond. We can see here the difference of this the double bond here, and you can see the in zeaxanthin it is placed here. So that's the structural variation. And lutein, zeaxanthin, and mesoxanthin, as we know, they have a strong antioxidant activity, and especially exclusively for the eye. So if you see the blue light, as we know, the exposure to blue light or overexposure to blue light, it causes damage to this pigment layer there, and causing the photooxidative stress and inflammation, which is the basic mechanism behind the damage of the macular pigments. And the daily intake of lutein can help to maintain macular health. However, this may be difficult to maintain through diet practically, and then supplements are needed. So if we look at the mechanism of the photooxidative damage in terms of the ocular chromophore ground state disease, and when the light is exposed, when it is exposed to the light, it is excited to singlet state and then to triplet state, which actually enhances the formation of free radicals and singlet oxygen, and which are actually scavenged or quenched by lutein and zeaxanthin, which is present in macula. As we know, lutein is mainly at the periphery as well as at the center of the retina, and zeaxanthin, lutein, and mesozeaxanthin, they are concentrated in macula. So if you look at the same article again, it mentions that the lutein and zeaxanthin are ocular antioxidants of dietary origin, and recent clinical trials have determined that the age and diet-related loss of lutein and zeaxanthin enhances the phototoxic damage. And supplementation of these carotenoids has a protective effect against the photo-induced damage. Now, evidence on lutein in age-related macular degeneration. And if we see here, I'm sharing with you the latest meta-analysis on the studies conducted with lutein supplementation in age-related macular degeneration, and which was published in December last year, 2019. And it included the 9 RCTs, the meta-analysis of 9 randomized controlled trials, which had the total 855 patients. And actually the evaluation of lutein supplementation, either with zeaxanthin or mesozeaxanthin, which was compared with placebo. And the parameters tested are were the MPOD, visual acuity, and the contrast sensitivity, and even the serum lutein levels. If we look at here, these are the basic characteristics of the studies, and we can see here the studies included, I think these were published, even we can see here the 2018, 2011, even 2013, 17, and the patients of the AMD, dry AMD mainly. Also, there were some patients of with wet AMD, but mainly it was of dry AMD. And if we can see here the intervention in terms of the lutein supplementation or lutein plus zeaxanthin, we can see here the 20 milligram per day lutein, or here 20 milligram per day, here again 20 milligram per day. There was a combination also lutein and zeaxanthin, and we can see here all these the various doses of lutein and zeaxanthin, and the measurement is mainly was the basically MPOD, and duration of these trials range from 3 months to even more than 1 year, that is 24 months, even the 2 years. What they actually found was this meta-analysis, and if we see the forest plot of these studies, we can see here, this is the A part, which is above, this is the upper part, which actually comprised of the studies which were conducted for less than 6 months of lutein supplementation, and this B part, which actually comprised the studies with lutein supplementation for more than 1 year. And if we can see here, this is the part where we can focus here. Basically, we can see the diagram here. The forest plot shows most of the studies, they fall in the favoring the lutein supplementation for AMD patients, and that's why the conclusion of this meta-analysis was the dietary intake of lutein 10 or 20 milligram per day for more than 6 months can significantly improve MPOD and visual acuity in AMD patients. Now coming to lutein in cataract, and basic mechanism of lutein for cataract, as we know, cataract is again the one of the highest prevalent condition in ophthalmology and one of the major causes of the vision loss. We can see here the basic mechanism by which the lutein can help. It basically helps to control the oxidative damage and spare the internal antioxidant strength, that is glutathione. So that is one of the important mechanism, because this GSH, glutathione, which is the most important intracellular antioxidant molecule in the lens. And if we see here, the lutein plays a very key role in sparing or regulating the glutathione there. Then lutein and zeaxanthin helps to maintain the membrane stability by protecting it against the lipid peroxidation. And it also efficiently filters the short wavelength blue light and thereby protecting the lens from photochemical damage. So basically, the lutein zeaxanthin play a crucial role in maintaining health and functional integrity of the lens. Now, this is again a meta-analysis of studies wherein the lutein and zeaxanthin intake in relation to age-related cataract. And here it included the 6 studies involving more than 40 or 42,000 participants. And it was actually they pooled the relative risk or the probability of the highest lutein intake versus lowest lutein intake and how it affects the risk of cataract. So if we see here again the forest plot for these studies, and we can see here again it is most of the studies, it is the relative risk in terms of the cataract, which is more with the lowest lutein intake. And we can see here in terms of the probability of having the cataract with the lowest lutein intake versus the highest lutein intake. And if we see here the comparison, it is for actually the risk reduction in terms of the highest lutein intake for the risk of nuclear cataract was 25% less as compared to the lowest lutein intake. And similarly for cortical cataract as well as post subcapsular cataract, again the significant low risk reduction in the group which had the highest lutein intake. And if we see here dose response in terms of risk reduction for lutein, every 300 microgram per day, that help to decrease the cataract, the nuclear cataract by 3%, in terms of cortical cataract 1%, and post subcapsular cataract 3%. So if we say even the dose, say even 5 or the even 10 milligram, we can imagine the kind of the protection or the risk reduction with the lutein supplementation for risk reduction of cataract. Now, lutein in diabetic retinopathy. As we know, diabetes is again one of the highest prevalent non-communicable chronic disease globally, and so also it is the numbers are increasing rapidly in Africa. And if you can see here, the 2019, the 19 million people, and going up to by 2030, it is up to 30 million, by 2045 up to 45. So it is actually increasing as per the number of that year. So if we can see here in terms of the 19 or 30 or 45, and if we can see here the problem of the diabetic retinopathy globally, or even if we look at the percentage, almost 35% of the total diabetic patients, they would, or the subjects, they would have some form of diabetic retinopathy. And if we see the 11% of the total diabetics, they would have a serious vision problem. So as we know, the role of basically the mechanism by how the diabetic retinopathy, which is actually caused by oxidative stress, which is the basic mechanism behind this development of diabetic retinopathy, which is triggered by this hyperglycemia and ultimately by these different pathways, and causing oxidative stress, increase in the oxidative stress, and then ultimately leading to inflammation, again inflammatory mediators, again leading causing oxidative stress. So this cycle, the vicious cycle, and that actually is responsible for the development of diabetic retinopathy. And if we can control this mechanism, then that is helpful in controlling the progression of diabetic retinopathy. Now here, I'm just sharing with you the compilation of studies which evaluated the effect of lutein and zeaxanthin on diabetic retinopathy. And these studies actually, most of these studies were the prospective studies, cohort studies, and we can see here one study was actually with the intervention, means actually the patients received the lutein and zeaxanthin supplementation, while rest of other studies, they actually studied the level of lutein and zeaxanthin and how it correlated with the risk of this diabetic retinopathy. And we can see here the patients with the diabetic retinopathy, the patients had the reduced optical, this MP optical density, and also the reduced serum levels of lutein and zeaxanthin. In terms of this one interventional study, wherein they actually found that the lutein and zeaxanthin supplementation helped to lower the diabetic retinopathy the risk, and with the actually improvement of these parameters like the visual acuity, then contrast sensitivity, and also even it helped to increase the serum and serum lutein and zeaxanthin levels. So that study summarized that the moreover the studies to also demonstrate that the macular carotenoid, lutein and zeaxanthin have the potential to prevent the development and or progression of diabetic retinopathy by ameliorating the oxidative stress and augmenting the neuroprotection and attenuating inflammation. So not only the oxidative stress is controlled, but also the neuroprotection. It offers the neuroprotection and it attenuates the inflammation. Now, as we know, currently there is a lot of exposure to blue light, either through smartphone or computers or other screens, and the average exposure is up to 3 to 9 hours per day, and this actually has increased the risk of even the occurrence of AMD. Even it may start early at around the 40 years of age. So eye health is no longer the priority of elderly. Now it is becoming a priority of young age group as well. And as we know, this lutein is the molecule which allows the absorption of light from all possible directions, and thus making it lutein making it the greater filter for this blue light. So it actually 40% blue light is absorbed by these carotenoids. Among these carotenoids, the lutein has the maximum capacity to absorb the blue light. Now here, this is the study where actually the lutein, the supplementation helped to improve the symptoms of this, basically the parameters, MPOD, as well as the photo stress recovery, as well as the other physical symptoms associated with this excessive exposure to blue light. And here in this study, the 48 young individuals were included, and they had 6 hours per day exposure to screen. And these patients, these subjects were given lutein and zeaxanthin combination, and which was compared with placebo, and the treatment was for 6 months. And it was found that the macular pigment optical density, MPOD, was significantly increased, and also the photo stress recovery was decreased, and also the other symptoms, the physical symptoms like headache, eye strain, in terms of the eye strain, eye fatigue was also improved. And it was concluded that the increased MPOD significantly improves the visual performance, and in turn they improves several undesirable physical outcomes with this lutein and zeaxanthin supplementation. Now, as we know, the dry eye, again, the prevalence is increasing, and one of the reasons, again, the increase the screen time, and that is also that actually contributes to decrease the blinking rate, and that also leads to dry eye. And here also, again, the lutein supplementation has helped to decrease the hyperosmoticity induced inflammatory damage, and that shows the role of this lutein in controlling even the inflammation, and therefore lutein may be a promising agent to be explored for the treatment of dry eye. Now coming to the next ingredient, that is the bilberry extract. Bilberry, the fruit, as we know, it's known as European blueberry as well, and it contains the anthocyanidins, which actually have the strong antioxidant action. They have the collagen synthesis and stabilizing action. They decrease the capillary fragility and permeability. That's how it improves the blood flow, and it has the affinity for pigmented epithelium of retina, and helps vision and adjustment to light and dark. So this is used. There are number of clinical studies with bilberry extract. It is used for improving visual acuity, night vision, cataract, degenerative retinal conditions. So why bilberry extract? It is one of the highest, it comes with one of the highest anthocyanin content. So if we see other the fruits or the berries which anthocyanin contains, and we can compare here with this bilberry, and the same the article, it mentioned that bilberry anthocyanins and blueberries, they promote rhodopsin synthesis and regeneration, increase retinal sensitivity to change in light intensity, improve visual acuity and dark adaptation, as well as improve blood supply to the retina. Therefore, anthocyanins should have a significant effect on age-related macular degeneration, diabetic retinopathy, primary open-angle glaucoma, and night blindness. So this is one, just I'm sharing with you one study with bilberry extract in preventing eye fatigue, wherein they studied 281 patients and who were given the 480 milligram of bilberry extract per day, and they were compared with the placebo for 8 weeks. And what they found was the ocular fatigue sensation and the symptoms were improved. Even dry eye sensation was improved, eye redness was improved, and eye heaviness was also improved. So that study concluded the bilberry extract supplementation improved some of the objective and subjective parameters of eye fatigue induced by the video display terminal load. This is again one of the latest articles, and we can see here it was published in 2018. It says that the polyphenols and carotenoids age-related eye diseases, and they would have it says that the polyphenols and carotenoids and their possible synergistic effect on the prevention and treatment of age-related eye disease. So the combination of polyphenols, or we can say here the polyphenols are basically, we can see the either these anthocyanins like bilberry extract, or from ginkgo biloba or quercetin or
Excuse me, Dr. Mane.
Yeah.
Yes, are we kind of running out of time? Is it possible?
Yeah, just 1 minute.
Yes,
I will just take a couple of minutes.
Okay,
so
maybe a minute or
coming
so.
to end. So we are introducing this product eye care in Zambia, and this will be made available very shortly. The composition is bilberry extract 25 milligram, lutein suspension 15 milligram, and suspension of D-salina extract 5 milligram, which provides beta carotenoid. The dose is 1 capsule daily with meal for preventive purpose, and 1 to 3 capsules or up to 3 capsules daily with meals for treatment purpose of these various eye conditions. So to conclude, eye diseases in elderly as well as in young age group are on rise, and major the damage is due to the oxidative photoxidative damage and inflammation. So the enhancing macular pigment density with antioxidant mechanism, and with the help of supplementation like eye care, would help to control the eye diseases, or help to maintain eye health in conditions like, say, basically the age-related eye disease like AMD or diabetic retinopathy or cataract, or also in young individuals with a digital eye strain or the eye fatigue or the dry eye, those kind of eye conditions. So before I conclude, there is just one slide on the another product that we have, which is high strength B complex vitamins formula, which contains all these B vitamins with this biotin, inositol, and the vitamin B12, which help for the neuronal function, the membrane conduction, integrity of membrane, conduction of the neuronal impulses, and helps to prevent or the control the peripheral diabetic neuropathy. So this is NADB. Thank you.
Thank you so much, Dr. Pramod. Dr. Lubea.
Yes, please. Thank you for that thorough presentation. I would just like to check with our participants if they have any questions that they will need to ask Dr. Pramod. Do we have anything in the chat or any hands that are up?
Nothing, Dr. Lubea. No questions, no hands.
Okay, so Dr. Pramod, you had hinted that you'll be having the product, the eye care, soon in Zambia. How soon is that?
It is very soon. It will be there. I think our local marketing team is working there. So definitely, it is will be made available very shortly.
Okay. I've seen Mr. Nalin has actually posted on the chat to say within a week it will be available. Yeah, so we really can't wait to see that product and make use of all those benefits that you've talked about, really. Yeah. Thank you so much for this presentation. Hope we have another interaction so that you could share more of the products that you have to offer. Because when you speak to us like this, then we know what is there. Sometimes we are working, we don't know the choices and options. Okay. Yeah, we get stuck to just the same thing. So I think this is commendable that we have choices. Even patients need choices. They've got a right to say, I'll take this medication, I will not take this one. You know, so this is very, very helpful. Yeah. Dr. Any words to the team before we close the meeting?
Yes, I would just like to thank you everyone for finding time. I know the presentation has been long. This was to be able to accommodate everyone. And then we had a small hiccup. I think we are using the COEX platform. Apparently, what we thought would accommodate 500, but only able to accommodate, I think, 115. We should be able to correct this problem next time we have the meeting. So our next meeting, we are going to revert back to Wednesday, and next week we're having a journal club. It has to do with keratoconus. The presenter is Dr. Kunda. And we are hoping to have a next international webinar next month. Thank you, everyone. And unless there's anyone who wants to make a comment at this point.
All right.
Just to echo your words, just to say thank you. Yes, Dr. Brea, just to thank everyone that managed to join this meeting. We had over 115 participants that came on. Thank you so much for joining us.
Fantastic. You've been such a wonderful moderator. Thank you to all the speakers and everyone who attended. Have a good evening to you all. Bye-bye.
Bye.
Thank you.
Bye. Bye.